No.
Thank you. Good afternoon, everyone. This is a webinar about polycystic ovarian syndrome. We all know that September is PCOS Awareness Month. This metabolic reproductive syndrome, which is otherwise called as polycystic ovarian syndrome, has created more paranoia than any other medical disorder. So it's not only about menstrual irregularities and subfertility, it's a huge spectrum of clinical symptoms spanning across all age groups. So it's not only a gynecologist problem, but also a fertility specialist, a nutritionist, a pulmonologist, and an oncologist. Everybody needs to be involved. So this webinar has been designed to address all the aspects of PCOS. I welcome all of you to this webinar and make the most of it because we have experts from all of the departments addressing all the concerns and actually knocking off all the myths associated with the disease. Next slide. This is a scientific program that we are going to have today. Next. So welcome address. I welcome all of you, the panelists and the delegates to this webinar. And this webinar, I want you to make the most of it. We have Dr. Shanti Gunasingh and Dr. Fatima, who will be the chairpersons. And we have experts from all fields, Dr. Supraja, who is a pulmonologist, Dr. Shaini, who is a nutritionist, Dr. Lakshmi Sheshadri, our beloved teacher, because Madam we have always fond of her teaching and have gone to CMC to attend her classes and sessions. Very welcome, ma'am, to this session. Thank you for joining. And we have Dr. Siddhartha, who is a fertility consultant. So we have a huge array of specialists who is going to help us solve the myths. Next slide. Dr. Jairani Kamraj, who is our OGSSI president, is unable to join because she's traveling. She'll be joining us as early as possible. Now we start with a Tamil Thai Vaalthu. Thank you. Now, the lighting of Kuttuvalakku, which will happen virtually. Thank you. Now I'll introduce, we have the OGSSI prayer, which will be said by our secretary, Dr. Kundavi Shankar. Kundavi madam is a very fond teacher and she is a diploma in reproductive medicine and diploma in advanced lab surgery. She is our very fond OGSSI secretary and a renowned national board certified teacher, specialist in reproductive medicine and laparoscopic surgery for more than 20 years. And madam holds a PhD. And we all look forward to her for all her fertility queries. Madam will be saying the OGSSI prayer now.
Thank you, Dr. Karpagam. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when all things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Thank you, Kundavi ma'am. Now, I welcome the chairpersons, Dr. T.K. Shanti Gunasingh, another beloved, revered teacher for all of us. Madam is an excellent academician. She's a consultant in obstetric gynecology at Mangalam Healthcare Center, is a president of Chennai Menopause Society, and past president of OGSSI. And she was a former director and superintendent of IOG and ISO KGH, and former HOD at Kilpauk Medical College. She served as a project director, Center of Excellence for Tubal Microsurgery for 6 years, and past president of Women Doctors Association, Tamil Nadu. Madam is a BMonk, CMonk, and SBA Tubal Microsurgery Masters and in Lactation Management in Adolescent Health. She has conducted a lot of adolescent health programs, and Madam is always eager to, whenever we ask for Madam as a panelist or a speaker for any dialogues, Madam has never said no, and she has always come forward for all the webinars and for all the conferences. Thank you very much for joining, Madam.
Thank you, Karpagam. Thank you very much. It's my pleasure.
Thank you so much, Madam. Next, I welcome Dr. Fatima Hassan. Dr. Fatima has done an MBBS from Madras Medical College and postgraduate from Stanley Medical College. She joined Tamil Nadu Government Service in 1996, and she worked in the Ministry of Health in Saudi Arabia for a very long time. And she's a faculty of obstetrics and gynecology in Stanley Medical College, Kilpauk, Vellore, Chengalpet, and Madras Medical College. She was awarded the Best Obstetrician Award from Honorable Health Minister in 2018, and she received the Sadhanai Penmani Award in 2019. And she is now the Associate Professor of Obstetrics and Gynecology at Institute of IOG, MMC. And special interests are field of obstetrics and gynecology. Welcome, Dr. Fatima. Both of you we're very glad to have both of you. And
thank you very much for inviting me for this a wonderful session, afternoon session on a Sunday. For the first time, I have joined as a member of OGSSI, and thank you very much for inviting me as a chairperson. Thank you very much.
Thank you, ma'am. Now we'll start the scientific session. The chairpersons will be introducing the speakers one by one.
Yeah. So it is PCOS had been addressed extensively in this webinar, and we know that women find it very difficult to lose weight in PCOS, although they do a lot of dieting and exercise, and all because of eating disorders in PCOS. So how to address it? Mrs. Shaini Surendran is here with us to give an idea about addressing eating disorders, and she's a very famous dietitian who's much sought after, mastermind in sports nutrition with Aska Jekendrep, and completed FOD MAP training with Monash University, Australia, certified in dietary management of IBD, and also she is very much qualified in various aspects of dietetic management. First Indian to be certified with graduate diploma in sports nutrition from the International Olympics Committee, sports nutrition course from Australia, and masters in food service management from WCC Chennai. And I welcome Mrs. Shaini Surendran to give her talk on eating disorders and PCOS. We are indeed very glad to have you, madam.
Thank you, ma'am. Good afternoon, everyone. Thank you, Dr. Shanti Gunasingh. It's such a privilege and honor to be here. I must thank all the doctors here, and especially Dr. Kundavi for having invited me for the talk. I'll just share the slides. Kindly let me know if you're able to see it, please.
Yeah.
Is this good?
We can see. We
Yes,
can see.
ma'am. Yeah.
Okay. Okay. Considering that I have 20 minutes, I'll dive deep into the session. I would also like to share some case studies so that you'll be able to see how we have managed it just by recommending locally available foods. So as we all know, PCOS is such a huge issue that we are tackling. And another major factor is also post-pandemic, we have noticed that all the youngsters have been glued to their either television sets or else their phone. The gadget usage has been really high. In fact, when I thought about this session, I was just thinking about one of the young girls who came to the clinic and who kept telling, listen, I'm not losing weight. And why is it I'm doing everything as you say? Then all that I asked was, could you share me your phone? And then I looked at the time spent on social media. She had spent around 4.5 hours. That's the average time that she had spent on phone. And she was sleeping at around 2:30 a.m. And she would wake up at 6 o'clock and then go to her college by 8. So this is a law graduate. So this is the state of affairs. And as we know, PCOS is such a huge thing. And I think all of us as professionals have various challenges. And these are some of those lesser known aspects like how gadget usage and of course, eating disorder is what we're going to be dealing with today. Okay, so usually when a client comes and talks about weight or rather being so obsessed with body weight, that's something when our antennas go up. Main thing is about, I've been checking weight like after breakfast, lunch and dinner. And every day when I wake up, the first thing that I do is check the weight. And even if there is a 200 gram or a 500 gram increase in weight, if they're getting highly stressed, if this is the kind of obsession they have with body weight, then we definitely sit up and take notice. And that's when we start looking for other pointers to see whether they need to be sent to the doctor and also to the psychiatrist of a psychological counseling. Next again is the intense fear of weight gain. Just last week, we had a client who wanted to shed weight, but then she said she doesn't eat breakfast because she's scared that she will gain weight. And what she does is go to a nearby coffee shop with her boyfriend and then have just the French fries. And in the evening, she might eat one fruit and after that, there's nothing at all. So there was hardly any food that she was taking. In fact, there were micronutrient deficiencies. But the main thing is I'll gain weight and I don't want to be eating the 3 meals. Don't you think it's too much of calories? So this is exactly what she had said. So this is intense fear of weight gain, again, is quite indicative of a disordered eating pattern. Loss of control while eating. So when they really go ahead and eat, they might end up having like 1 biryani or else 2 biryanis, or it could be like a burger, just going towards binge eating also. So it could either be anorexia nervosa or else a binge eating disorder, or it can even be a bulimia. And also feeling very guilty after eating. So quite often when they say, I went to a temple and they gave me some prasadam and then I didn't eat it, I was being really good. So in fact, making sure that, they just don't have anything with sugar or fat, but then there are days that they will overdo it. And then again, guilt sets in and there's no moderation here. This is the pattern that we get to see in a lot of our clients. And compensatory behaviors about exercising quite a lot, counting calories very, very diligently using an app, and then also purging or sometimes even restricting certain food groups completely. So these are things that we should definitely be paying attention to. So main thing is being obsessive about food. It could be that, they're looking at only health food. So if they're eating only health food, again, we have a new term for it. That's orthorexia, just eating only nutritious food and not even 1 teaspoon of sugar. So in fact, most often we keep telling there will be festivals, there'll be birthday parties. It's okay to have that small piece. It's all about portion control. Next is again the behavior change. So they might come with a goal of, say, shedding weight, but then after a while, they'll say, oh, no, I'm having a lot of facial hair. I want to fix that. And then later they'll say, I want to lose another 10 kgs because I want to look good for a cousin's wedding, or there is a get together in the college. So these are the kind of things. And there's a lot of behavioral changes. They keep hopping from one goal to the other. This is another major sign to look for. Another factor is also that they have very distorted beliefs about their body size. And body composition analysis is the key, and not just body weight, because there could be water retention. And if they have gut related problems, and that could also contribute to a lot of their weight. And also if they're on antibiotics, or if they've just been recovering from COVID, or if they have any kind of health issues, enteric fevers or whatnot. So again, that could also contribute to weight gain. But if they are checking their weight couple of times in a day, you can't explain that slight increase in weight which happens throughout the day. So this is another major hassle that we have to deal with when we interact with individuals with eating disorder. Another thing is also really struggling to concentrate on their studies or else at their work, and also disappearing after meals because they might end up with purging. And they also exercise a lot, around 4 to 5 hours a day. So if they are in the fitness center a lot, so there are times that we do ask the fitness trainers or the physiotherapists to see, is there an injury history? How often are they coming to the clinic and that they're not reporting? And also, how many hours they are in the gym? And are they vigorously exercising, because the chances of injury is very, very high. So trying to ensure that we interact with all these professionals simultaneously will help in giving better service to the client. And also if there are issues, then immediately inform the family members so that they can take them to the psychiatrist and as well as the concerned professionals. And we all know in PCOS, what are the biggest issues that the individuals or the girls face? Hirsutism, constant acne, menstrual disturbances, and of course, we also get to see pre-diabetes or insulin resistance. And this can affect their self-esteem to a great level, and depression, anxiety also sets in. Another most important factor about insulin resistance is there are times that we have seen that they make such gross mistakes because it's all about the degree of insulin resistance. And a lot of people just skip meals and they literally live on apple, beetroot, carrot juice or else a big bowl of fruits, thinking that that's going to help them with weight loss, because it's not just about calorie restriction, but about the kind of foods that one should be eating so that they're able to manage the insulin resistance effectively. So fruits, in fact, is so high in fructose, and that itself can trigger the release of insulin, which in turn is going to convert whatever they have consumed into fat, and their waist-hip ratio is going to increase in size. And without this awareness, if they're going to constantly literally live on juices and smoothies and smoothie bowls, then there's another huge problem. And the degree of insulin resistance varies so much, because there are few clients who are absolutely fine by just eating, like say 2 idlis for breakfast and then half a cup of rice for lunch, and then again say 2 rotis for dinner. But then there might be individuals who have to just completely avoid grains and eat only a lot more protein, good fats, and high fiber vegetables or low starchy vegetables. So again, these are things that a client might not be aware, but then just take information from, say, social media or from anywhere else without seeking professional help. And they get into this cycle, vicious cycle of weight gain, weight loss. And when they don't see results also, they get frustrated. Then they slip into depression. And then there's anxiety and again, body image issues. So this is the huge problem that we get to see among our youngsters. And of course, negative body image, fatigue is another major issue, weight gain, and because of which there could be depression, because even after exercise, if they're not able to see any results, that really puts them in their backseat. And another issue could be also back pain. And because they're not eating, because they're trying so many different methodologies, nutrient deficiencies are very, very rampant. And this is a major thing because they end up losing quite a lot of hair. And on top of it, they already have like hair thinning, and they would shed quite a lot of hair if they have not been eating certain food groups. They might just eliminate food groups completely, and that can result in major deficiencies. Low progesterone levels, and of course, increased stress hormones. And if they're not sleeping on top of it, this also adds to the burden. And next is if they're not taking adequate fiber and also gut-friendly food, like say buttermilk or else like curd, and also taking fermented foods, if they're not taking any of this, and constipation could be an issue. Lack of physical activity also influences gut health, and that's another thing that we get to see. And thyroid related issues. So PCOS come the hypothyroidism. So various combinations that we get to see along with eating disorders, and there could also be depression and anxiety, and of course, low energy levels. So most often when we get to see a lot of studies, what we also see is the main thing is that they definitely are very, very dissatisfied with the way they look, which is that there's so much of facial hair, they even resort to laser treatments and all that. Another thing is also constantly checking their body weight and looking at themselves and not being able to fit into certain dresses. And they try to avoid going to social gatherings. And this has happened, and this has been one of the major concerns among parents when they bring their daughters to the clinic, and not getting their periods regularly, and constant increase in their waist-to ratio. So the truncal obesity or the abdominal obesity is so high. Another thing is also the acanthosis nigricans as well as the skin tags, and they really don't like the pigmentation or the change in the color in their face as well as their chin and all of that. And that again really makes them so rather restricted to home. And this is one of the biggest issues, and they're so dissatisfied with the way they look. So sense of self-worth, self-esteem and all is like really low. And because of anxiety, they're not able to cope up with either their sporting activities or else their regular life of going to college or to school and coming back. And also the interaction, either if it is, if they're working somewhere, even their interaction with their peer group is also affected so badly because of this constant body dissatisfaction that they have. So I think it's a multi-pronged approach for us to look at it from every angle and constantly interact with the doctors as well as the exercise specialists, as well as the yoga therapist, the physiotherapist, or whomever they are interacting with. It's better to see their circle and then connect with them and share information about what kind of diet they're in. And if there are any inputs from the physiotherapist or the trainer, that also becomes very helpful for them. And the main thing is also to look at the inflammatory markers. So usually when we get to see the blood test reports, we explain what could happen when they're not eating right, and how inflammation is one of the most important factors when we really look at the issue at the cellular level. And of course, the endocrine disruptors that comes into the diet, and also the estrogen dominance that could be there. Blood sugar imbalances are also another major issue. And if they are constantly going to be skipping meals and then eating larger meals and then trying keto diet, paleo diet, LCHF diet, and all sorts of things that they see or hear, and these could be people who are unqualified, and then but they just take it from face value from what has been shown in, say, in television or else in social media, and that also affects. So they're constantly into this cycle of trying various things and not being consistent with one methodology. And of course, without any scientific backing, they'll go nowhere. And nutrient deficiencies, as I mentioned earlier, constipation, diarrhea. And another important factor is also how the kind of food they eat is going to affect their mind in a big way, the food and mind connection. So neurotransmitters like serotonin, which is very important when we actually include complex carbohydrates along with a lot of fruits and vegetables. That is, the food diversity score should be quite high, so that they're eating a variety of foodstuffs and not being fussy and then not eating adequate range of food groups. So this is how we teach them, trying to show them the food plate. This is the most simplest way in which we communicate to our clients. We say, split your plate into half and make sure the one half of the plate is filled with low or non-starchy vegetables. So potatoes, colocasia, yam, carrots, beetroots, yellow pumpkin are completely avoided. But then we encourage them to take a lot of gourd vegetables, capsicum, cabbages, broccoli, turnip and radish, and white pumpkin, cauliflowers, and all of that. And on the other half, if you notice, you do see protein-rich food, and the other quarter is for the grains. Now, the quantity of grains will vary, and it might again change. It can either be for 2 meals a day or else for 1 meal a day. But then a lot of carbohydrates will come in from the lentils or the dals or the sundal that they are consuming. Sprouts also is added to their diet, and we try to bring in a variety. So it could be mushroom, tofu, tempeh, and then non-vegetarian dishes. Okay, so ensuring they are getting adequate protein. So at least around 1 gram per kg body weight of protein, along with good physical activity. So I would like to share a case study. So there was this girl, 23-year-old, who came. She was working in the IT industry, and her height was around 164 centimeters, weight around 76 kgs. Fasting sugar was around 75. And if you look at the HbA1c is 5.2, cholesterol values are mentioned, and her vitamin D was really low. And she was having very irregular periods, and she also had migraine. So usually when someone has migraine, and if they want to try intermittent fasting and all, the first thing that we say is kindly avoid, because gaps in the meal pattern will lead to low blood sugar. That's going to trigger the migraine. Another issue is also that she was lactose intolerant. So this again, and without knowing if she's going to continue including a lot of milk and cheese and chocolates and ice creams, the milk solids which are there can trigger migraine episodes. So in that case, what happens is she won't be able to do anything for the next 2 days of a migraine attack. So won't be able to go to the gym or else even eat properly. She'll be in a dark room, and she would shut herself herself out. She will even take a break from her office work. She had gained a lot of weight during the pandemic, and her requirement was that she wanted to get her PCOS reversed. And also, if you notice, there was no physical activity. So this is her dietary call. If you look at it, like she was waking up around 10:30, 11, and then she would have Diet Coke. And then if she was hungry, she might either have like a bhujia or else a chocolate bar or some boiled peanuts, or she might even have some almonds. She was living by herself. And then lunch, if you notice, she had stopped eating rice and she was literally on cauliflower rice along with some chicken, because someone told her that protein there is going to be helpful. Again, around 4 to 5 o'clock, she might either have like some non-vegetarian dishes or else hot chocolate. 6 o'clock was Diet Coke, because she thought the calories are low and that's going to be very beneficial for her. And dinner would be again steak or else pasta or else grilled chicken. And in a day, if you notice, like, her water intake was less, but her Diet Coke consumption was high. Over a period of time, we taught her about what needs to be done on a daily basis, what snacks to carry to office, and also how to increase her physical activity, sleep on time, reset the food in such a way that her gut health is restored. So all this was done, and over a period of time, if you notice, she saw some great results and they were very good inch losses. So if you look at the waist measurement from 88 centimeters, it had come down to 69 centimeter, and abdominal value also from 92 centimeters to around 73, and hip again from 110 centimeters to around 97. Usually we put them on a 3-month program, but then if someone is very inconsistent, then we might end up working with them for around 6 months. So another thing what we did with her was to give her adequate water, because if they drink less water, they're going to be eating more. So thirst, again, if it's very predominant, then they might perceive it as hunger and eat a lot more. So first change was adequate hydration. Next was including at least 1 fruit a day. Making too many changes can overwhelm the client, so we just start with baby steps. And next is include 1 variety of vegetable in the meal, because she wasn't eating anything and she was eating only chicken a lot. And by the end of 3 months, she started drinking around 3 liters of water, and she started making better choices whenever she was traveling or also over the weekend and in different circumstances. And weight loss result, but the main thing is we have a body that is bioelectrical impedance analysis machine in our clinic. So she would come regularly and get her fat percentage checked, visceral fat, subcutaneous fat, as well as her muscle mass. So that kept her motivated, because she knew what was happening inside her body. And also the periods got regularized. She started getting regular menstruation after 1 month of eating right and exercising and daily monitoring through WhatsApp. Every day she had to post pictures of whatever she was eating and drinking in the WhatsApp. The next one is a postgraduate doctor. She was doing her gynecology in SRMC. And here, if you notice, she again, around 28 years of old, and being a doctor, she was undergoing a lot of stress because she was doing her PG in gynecology and her weight was quite high. Her father also is a doctor, and she had a lot of family support, and she came up with all these issues. And if you notice, she had lost a good amount of weight, and of course she's continued to maintain it this way. Okay. And I would also like to show that, so for this particular individual, if you notice, within a month, she had lost around 4 kgs using the same food plate method, and her menstrual cycle became regular. Another factor was also she used to study late at night and sleep by 3 a.m. only. But then once we started changing all the sleep wake cycle, exposing body to sunlight, and also ensuring that she was taking at least 3 cups of vegetables, that to non-starchy vegetables, close to around half a kg of vegetables a day. And then also fine-tune the quantity of rice. So 1 cup of rice and 3 cups of vegetables on her plate. So this is how we had actually worked, and consistency being the key, and ensuring that we educated her on the right kind of eating and not getting carried away by information on social media. So when we look at balancing blood sugars, main thing is to ensure that even if they are eating rice or anything that's locally available, bringing in fiber, protein, and good fats, omega-3 fatty acids in their diet, or else it could be flaxseed, chia seeds, subja seeds into the diet, helped a lot. And it's not about dieting, but about a way of life. So we would always tell our clients, just like how you wake up in the morning, brush your teeth, use the restroom, have a shower, and go to work, eating healthy should be a sign of self-respect and also about self-love. So start eating healthy, choosing healthy, so that you're nourishing your body with nutrients, and do not get into this entire vicious cycle about dieting and restrictive eating. So this is the last case study. This again, she's a doctor from Chhattisgarh, and for her, she actually wanted to have a baby. The main thing was she had hypothyroidism and her menstrual cycle was irregular. And later, once she got started, within a month, she had a lot of gut-related issues. We showed the food pyramid and taught her all of this and encouraged her to move a lot more, non-exercise activity thermogenesis. And by the second month, she had conceived, and then we supported her throughout the pregnancy. So this is what had happened. And also when she lacked motivation, we recommended that she meet a psychologist in her city, and that helped her a lot to stay more motivated. The cognitive behavior therapy, that is CBT, was used by the psychologist. So the main thing about PCOS management is also helping them understand digestion, and then making sure that they avoid foodstuffs that they are allergic to or intolerant to. So we see a lot of non-celiac gluten sensitivity cases and also lactose intolerant cases. So we ask them to avoid these. We encourage them to maintain a food diary. And another thing is also that food needn't be about counting calories only, but there is also a source of comfort, or else, there's also pleasure, or, there's communities which come together, and food being the common link. So we shouldn't forget that aspect of their life. And then ensuring that fiber, water, and protein is there so that it promotes satiety, and to prevent overeating, ensuring that their meals are equally well spaced, and also making them understand about the body set point, and focusing on increasing muscle, reducing fat, rather than just the weight on the weighing scale. So the idea was to promote healthy food choices as a lifestyle. So I end my presentation. I would really love to take questions if you have any. And I would like to finish this by the quote by a functional medicine doctor, Dr. Mark Hyman, that food isn't like medicine, it is medicine. And it is our #1 tool for creating vibrant health we deserve. Thank you so much for this opportunity, Dr. Kundavi, and the president, and all the doctors present here. Thank you so much.
Thank you very much, Shiny, for giving us a lot of useful insights into eating disorders in PCOS. And it was really interesting to note about your lips, flips, hips. This is the first, I was not aware of this earlier. And you have stressed a lot on mindful, healthy eating, which really goes a long way for them to enjoy the food too. So thank you very much. Okay. Now I hand over the podium to my co-moderator, Dr. Fatima.
Thank you very much, madam. Yeah. Something happened.
Heard, Fatima?
Fatima, madam?
You heard?
Yes, madam. Yeah.
I'd like to introduce Dr. Supraja, who is the Director of Pulmonology and Pulmonary Rehabilitation, Medway Institute of Pulmonology. The 14 years experience, she's also a young investigator. She's got the ERS Young Investigator Award at UPSA 2019, Vietnam. Her areas of interest are airway disease, rehabilitation, genetics, and sleep apnea disorder. Member of the Indian Chest Society, European Respiratory Society, and Association of Pulmonologists of India. She has her 6th indexed publication and 1 book chapter. She's here to discuss with us regarding sleep apnea and PCOS. And this has been really, even I am suffering from actually sleep apnea, and I am keeping CPAP. I think it's apt, even I have to see, because I am having sleep apnea and was diagnosed with only epistaxis, because when they found the cause of epistaxis, it was due to prolonged hypoxia, induced erythropoiesis, and then increased hemoglobin, polycythemia, and last year I had severe epistaxis. And see, sleep apnea was representing for me like with epistaxis. So when after keeping CPAP and when I sleep, then only I knew world day where my energy went. And oxygen is so important for a person. So I hand over the mic to Dr. Supraja to enlighten us regarding sleep apnea, which is important for the young and also for the elderly.
Yeah. Good
Thank you.
afternoon. Yeah, thanks, ma'am. Thanks for the kind introduction. And thanks to Dr. Kundavi for inviting me for this talk. A topic which is very close to me. I do practice it on a regular basis. So this is very specifically addressed one as OSA in PCOS. In fact, a lot of learning from my end as well, because OSA we see on a different spectrum, but PCOS, the mechanisms are slightly different. So let's see how it goes. Yeah. So the overview of my talk is going to be what is the prevalence of OSA in PCOS specifically, world and in India. What is the mechanism? What happens? Why do they develop OSA in PCOS is another thing. What are the risk factors? How do they present? Diagnosis, treatment, and prevention. So this is going to be my overview. But before going into the topic, so let's talk about what are the stages of sleep. Ma'am, is my slide visible?
Yes, Dr. Supraja.
Okay.
You can
So
carry
there are
on.
5 stages of sleep. Stage 1, 2, 3, 4, and then there is a REM stage. So stage 4 is a very deep sleep, which only babies do. We all go between stage 1, 2, and 3, and then we have a phase where we dream. That is the REM stage. The REM stage is very important. We need to dream, and it occurs once in 90 minutes, lasts for around 15 to 30 minutes. So if there is a disruption even in the REM stage, then we have issues with that. And stage 1 is basically a very light sleep when you start closing your eyes and go to bed. So breathing and muscle activity start to slow down, and it's very easy to wake up from this stage. Stage 2 is when the sleep starts setting in. So the heart rate slows down even further and the temperature starts dropping. Stage 3 is quite a deep sleep. Then there you start getting waves which are called as delta waves, which are very slow brain waves, and the muscles are completely relaxed. And stage 4 is very, very deep sleep. And that is the stage where the body repairs itself. So it was very interesting to note in Ms. Chinese talk, where when person sleeps between 3 to 6 a.m. in the morning in the first case study, they do not get into the deeper stages of sleep. So when you do not sleep well, the body's ability to repair and rejuvenate itself doesn't happen. And REM phase, the beauty of REM is everything is active, brain, heart rate, and breathing, everything is very active except for the market thing is the hypotonia of the muscles. Muscles should be completely hypotonia. Otherwise, you will start seeing night walking and walking disorders during sleep. So how much of sleep do we generally need? From a newborn who requires around 12 to 18 hours, in a fully grown adult, we actually require 7 to 9 hours of sleep. 7, I think, in a busy world where we are all racing against time, is an ideal thing. Lesser than that, if you're used to it, tuned to it, yes. Otherwise, we should recommend 7 hours of sleep per adult person. Coming on to prevalence of OSA in PCOS, because the difference in OSA in the world is different. So generally, during sleep, sleep constitutes 30% of adult life, and we call it as the golden 8 hours. So we divide the 24 hours into 8 hours for sleep, or basically physiological reset to promote a good, healthy metabolic and cognitive function. 8 hours is for work, and 8 hours is for personal time with family, time included. So what is obstructive sleep apnea? So apnea means you stop breathing for 10 seconds. So there is a complete cessation of airflow. And obstructive means there is an obstruction which happens at the upper airway. So the obstruction happens at the level of the neck, but there is a continued chest and abdominal effort which is going on. And OSAs are very significant and they're highly under-recognized. It's still like tip of the iceberg. World over, there have been studies, the meta-analysis studies have shown that the prevalence is around 32%. These are studies which are included from US, China, and the United Kingdom. In India, the prevalence is quite varied from 11 to 74%. That's because of the type of study, the people they are including. It's quite varied. In Tamil Nadu, there was a study by Institute of Thoracic Medicine where they had done this test on 60 females with PCOS, diagnosed PCOS, and they found that it was around 10% was the prevalence of OSA and PCOS. Now, coming on to the mechanism. Now, all of us know from the second half, like what is obstructive sleep apnea and what happens, but what leads to obstructive sleep apnea is what you all have discussed so far, like hyperandrogenism, your decreased estrogen and the progesterone, the obesity and visceral adiposity, and your insulin resistance. All four mechanisms put together result in increase in weight gain, visceral fat, the neck circumference, and results in obstructive sleep apnea. And what happens in OSA? So when a person sleeps, they can be snoring or they need not be snoring. And then the breathing stops for a few seconds because either the tongue falls back or the fat around the muscles, neck muscles compress each other against each other. So there is a reduction in the airway passage for the air. So when you stop breathing, what happens? The brain cannot sustain it for more than few seconds. So it wakes you up. You then start breathing again. So we call it as a pattern of snoring, apnea, again snoring with a jerk is what we generally ask the patients about. So this results in frequent sleep fragmentation. You can imagine if somebody is sleeping and you suddenly go and close their nose, there will be a jerk, right? So like that, if that is going to repeat 15 to 20 times or 30 times in an hour, which is like almost every 2 minutes somebody is waking you, that's definite sleep fragmentation. Now that will result in increased, restless state in the body. Second, there will be a sleep lag, which is going to get accumulated. We call that as sleep debt. And this intermittent hypoxia is going to lead to an oxidative stress. The lipid metabolism is going to be altered and the sympathetic overactivity is going to set in. And there's a lot of inflammation which is going to come in and there is an endothelial dysfunction. That's because during sleep, everything slows down. The heart rate, the blood flow, everything comes to a basal metabolic rate. But every 2 minutes, if they are made to come to full activity, they go into a state of stress. And this will increase your insulin resistance, your beta cell dysfunction, and your glucose intolerance. So OSA and diabetes, they are partners in crime. And when you add PCOS, yes, they work very well together. And we do see a lot of cardiac cases in obstructive sleep apnea. Now, in PCOS, the major thing is the visceral adiposity is the most important thing. As Shiny said, we have to look into the VCM, and it's not just the BMI alone. And the insulin resistance is partly because of the visceral adiposity. And when the sleep deficit keeps accumulating, there will be an alteration in the lipid metabolism. And the alteration in the lipid metabolism, it will result in a something which is very essential called as the flight and flight response, and it will lead to your beta cell dysregulation. I'm sorry, this slide is supposed to be a video, which is not playing here. What are the risk factors that we look into? In PCOS, we have obesity, mainly the visceral, the central adiposity, and your increased neck fat deposition, which is happening. And androgens, hyperandrogenemia is the predominant feature. So testosterone will actually produce a lot of fat deposition in the body, and visceral fat, neck circumference, and hypothyroidism. And there is a change in the, like hirsutism comes in, your pharyngeal anatomy starts changing. These can also result in obstructive sleep apnea, especially in the chin, jaw, if you have macrognathia, retrognathia, large tongue. All these are very easy structures which can, when you're lying down flat, it can obstruct and obstruct the airway breathing. And hyperandrogenism alters the sleep architecture as such. And in PCOS, we all know that there is a lot of mood disorders which come in, like anxiety and depression. So there will be a change in the eating pattern. They gain weight, and that predisposes to OSA. And OSA, again, they wake up frequently in the night, they feel hungry, they eat, and they gain weight more. So it becomes like a vicious cycle. We cannot, in this day and age, be without touching on genetics, because every study, every disease is now, we are looking into what is a gene and what is the environment. So if you look at, these are the number of genes that are being playing a role in PCOS. And I was amazed to look at the number of genes, but the gene that is of interest to me is the FTO gene, because that plays a major role in obstructive sleep apnea. So if you look at it, the genetic variants controlling weight gain and insulin receptor sensitivity is FTO, INSR, and LMNA. Now, this will result in gaining of weight. In future, possibly we will be doing like a point of care study as to, we will look, predict people, if they have a mutation in these genes, they are more predisposed to developing a OSA in PCOS, and probably we can address early initiation of interventions. Now, if you look at the environmental factors in PCOS, so if you look at, it starts from the maternal socioeconomic status, the fetal development, the endocrine disrupting chemicals, all these factors come into this. So the child suddenly does not develop PCOS overnight, right? So it is happening through multiple things. So from the womb to the environment, there are so many factors which are responsible. And add on to vitamin D deficiency, gut microbiota plays a major role. And this S-RAGE, serum S-RAGE, plays a major role in a lot of inflammatory, it's an inflammatory marker. So it plays a major role in multiple diseases as well. And ultimately, all of this will result in weight gain. So if you gain weight again, it goes back into the same vicious cycle. So whether can we identify in future the genetic point, the environmental causes, and of course the personal lifestyle, what the person is having, and if we can predict that they are going into a PCOD, then we can do some early interventions in such persons. Now, how do these people present? So we call them as nighttime symptoms and daytime symptoms. During night, usually the partner comes in complaining, "Doc, my spouse is really snoring a lot. In fact, they go and sleep in different rooms." And there are witnessed pauses in breathing. Like they snore, there's a pause, and then they start snoring. And then there is a choking or gasping for air, which happens. And they're restless completely during their sleep. They keep tossing, they keep kicking their legs, and they are, no, because that's because of hypoxia. And sometimes there can be frequent visits to the bathroom. Daytime, they would have slept for 7 to 8 hours in the night, but when they wake up, it's like, okay, I've not had enough sleep. They always keep complaining that they've not slept well. And they wake up with early morning headaches, drowsy during the day, poor concentration. They're always irritable. And in a meeting or in a routine activity, like they're watching mobile, or they're reading a newspaper, or they're in a meeting, they tend to doze off. These are very embarrassing for people, especially because it happens in later part of our life, like above 40, and that's when you're in the major positions in your life, and when that happens, it's very embarrassing. So what is a consequence of OSA in PCOS? So most important thing is insulin resistance. There was one study by Alexandros. PCOS is associated with OSA and daytime sleepiness. So we need to start looking into such data in India as well, because it was I found only 5 studies from India. Sleep disordered breathing is very frequent in PCOS, and PCOS plus OSA, there's a higher plasma insulin levels and a lower glucose to insulin ratio, which happens. And insulin resistance is a stronger risk factor than your BMI in these people. And when you look at glucose intolerance, this was a study which was done by Tasali. So there are 2 columns, column A and column B. Column A is normal glucose tolerance. So you are having the glucose levels. There is a light line and there is a thick line. So the thick line and light line are almost coinciding with each other in group A with the normal glucose tolerance, right? Whereas when it is an impaired, the thin one is actually for people with PCOS. So the sugar levels slightly shoot up for these people. And the same way, when you're looking at the number of insulin, uh, plasma serum insulin, with time for these people, especially the long strand ones are the PCOS people. So their insulin levels are quite high in the system. And what are the other consequences in terms of medical complications? Because of repeated waking up in the night, your pressures are going to go up, your sugars are going to go up. There is a chance that there can be arrhythmias, either it can be brady or it can be tachy. And these arrhythmias can lead to, because prolonged hypoxia can lead to a heart failure. In fact, we used to tell people they died during their sleep. So sometimes it can be OSA producing a cardiac arrest and a death. Sometimes it can be a coronary artery event like a heart attack, stroke, depression. All these can be the major complications for OSA. This can be in OSA in any condition. And in workplace, embarrassment when they are not performers and when they doze off during the work. Transport is when people doze off in vehicles. This can lead to a lot of road traffic accidents. And economic is the huge financial burden that we are faced with whenever we are having patients with OSA who get admitted. They go through a respiratory failure in and out of ICU. The cost on the family and on the government is huge. Now, how do we diagnose obstructive sleep apnea? So first, most simplest thing is a questionnaire. Okay. The left one is a little complicated. It's the Epworth Sleepiness Scale. Whether the person is dozing off while sitting, while watching TV, while sitting inactive in a public area, or while lying down to rest in the afternoon, and sitting and talking to someone, does he doze off? And when he's sitting quietly after lunch without alcohol, does the person doze off? And in a car, do they doze off? So this is the Epworth Sleepiness Scale. The other one is very easy, stop bang, which is called, do you snore? Are you feeling tired? Has anyone observed you stop breathing? Is your blood pressure high? That is STOP. BMI more than 35, age more than 50, neck circumference more than 40, or gender is a male. So if it is a high risk, it is 5 to 8 is a high risk. This is when you refer the patient, because it is very important to first identify. Only when we identify, we will refer. There are sleep studies. There are four levels. This is the level 1, where we'll monitor the brain activity, the cardiac activity, respiratory, and the muscle activity. When it is level 3, it is only the respiratory and the abdominal muscle activity which we monitor. So what are the treatments that are available? Most important, weight loss. I think Shiny can help all these patients with a program. So we all need to incorporate weight loss programs in our regular schedule. And if there is a nasal obstruction, first we have to relieve it before starting therapy. Third is avoid alcohol. It worsens, because the only system which is awake to wake you up is the brain. And if you put that to sleep, that will worsen your obstructive sleep apnea. Fourth is sleep hygiene, consistent sleep wake times, avoid alcohol before bedtime, positions, and avoid caffeine, and smoking cessation. Devices, we have mandibular advancement devices, we have tongue retraining devices, but by far the most important is this continuous positive airway pressure. And there are other devices which are called as the hypoglossal nerve stimulators. Okay, the video is again not playing. So why do you think we need to treat obstructive sleep apnea? Okay, before that, I'll explain this video. So when you wear this mask, this is called the continuous positive airway pressure mask, CPAP mask. It's going to be connected to a device, and the air will come through a pressure through this tubing, and it's going to be secured with straps, because it's going to come at a little higher pressure, so that the mask cannot be displaced. So what happens is the obstruction is happening at the level of your pharynx. So the air gets pushed against the pharynx, so that the airway is patent and air goes in smoothly, and you sleep like a baby. As ma'am said, It's a world of difference when you are, having OSA and you're getting treated. It's a world of difference. In fact, I don't do a huge amount of counseling because I just recommend them just try it a day and come back. They will come back and tell me what a difference I have made in their life. So why do you think we should treat OSA? The first and foremost, the partner. Partner will sleep well because person is not snoring. Patient sleep will improve. Daytime sleepiness will reduce. Cognitive, their memory will start improving, and the pressures will start improving. We have written papers on how the heart rate and the rhythms changes improve, and there's a little bit of evidence on reversal of pulmonary hypertension. So prevention is identification, and most important, we need to identify, and when we need to refer when they have difficulty in starting sleep, difficulty in maintaining sleep, there is excessive daytime somnolence, unrefreshed sleep, and the stop bank score is 5 to 8. Please refer the patients. Where do you refer to? I am always available, a phone call away, and our institute is in Trustpuram, Chennai, Kodambakam. I'm always there to help you all. Thank you. And thanks for the patient listening.
Thank you very much, Dr. Supraja, for your very enlightening speech. Because I felt personally because I didn't know about all this. When I came to know, I was telling everyone about this so that everyone should know about sleep apnea. And you have enlightened us that even in younger age, even girls with PCOS have sleep apnea. This is what we did not know. And you very well told about the deep sleep is very important to repair our body, and how even OSA affects lipid metabolism, and further it worsens the glucose intolerance and makes them more obese. And about the genetic predisposition, which was enlightened us that genetically sleep apnea and PCOS is transmitted, and how OSA worsens and worsens if they have not taken treatment for that. PCOS can never be treated, and how exercise is going to help them. So thank you very much for this enlightening speech. Even we elderly also will be knowing about sleep apnea, because most of us will be snoring and we are ignoring it, and I had ignored it for a long time. And now I am really feeling like I'm nearly 19-year-old with full energy because I'm on sleep apnea. Thank you very much, Dr.
Wonderful, ma'am. Thank you. Thank you so much. Kundavi ma'am, thank you so much for inviting me once again. And thank you all.
We know that obesity is always associated with PCOS, but then we understand that 20% of our PCOS girls and women are really very thin. So what about the metabolic risk factors? Does it hold good for both obese and non-obese? We have our Dr. Jayashree Gopal, consultant endocrinologist, and I always like to happily call her as one of our own. She's also in our Chennai Menopause Society as an EC member, and she's always available for all the OGSSIans since half OGSSIan, I think. And she's Director DIAB in Endo India, Chennai, and founder trustee of DIAB Endo India Foundation, preserving health across generations. She's a diplomate of the American Board in Internal Medicine, Endocrinology and Diabetes, and a senior consultant endocrinologist and diabetologist, Apollo Hospital, Chennai. She is vice president, Endocrine Society of Tamil Nadu and Puducherry, and recipient of the Occasional Excellence Award from Rotary Club. She herself has written 2 books and non-medical. Awarded the Dr. Sam G.P. Moses Oration at the API Chennai Chapter Annual Conference. So I invite Dr. Jayashree Gopal to give us an insight into the metabolic risk factors in thin and obese PCOS.
Thank you very much, Dr. Shanti. Can you see my
Yes.
full screen?
Yeah, full screen.
Yes, madam. Yes, ma'am.
Okay. That's always a bit of tension till that happens. Thank you once again to OGSSI, and thanks to Dr. Kundavai for inviting me here. I'll be talking about the difference, if really there is, between lean and obese PCOS. So PCOS as a constellation of polycystic ovaries on ultrasound and ovulation, either manifested by irregular cycles or infertility, and hyperandrogenism, which could be either clinical or biochemical. And of course, according to the Rotterdam criteria, we need any 2 out of the 3 to make the diagnosis of PCOS. And obviously, we don't rely on either BMI or blood sugar to make a diagnosis of PCOS. So the concept of whether you're lean or obese doesn't really come into the diagnostic criteria. The way we, I would say, at least I and most endocrinologists would think about PCOS is that it is an ovarian manifestation of the insulin resistance. So the way we think about not only dysglycemia or hypertriglyceridemia or fatty liver, OSA, again, PCOS is one more manifestation of that same insulin resistance. So while obesity is certainly a risk factor for PCOS, of course, we all know that not all obese women develop PCOS, and similarly, not all PCOS are obese. Like Dr. Shanti mentioned, somewhere around 20% of girls with PCOS are what are called lean PCOS, and I'll come to what we mean by lean. In a study that we did a few years back looking at one aspect of PCOS, similar, we found somewhere between about 16 to 18% of our young girls had a BMI of 23, and 4 out of 41 had a waist circumference less than 80 centimeters, but presented with PCOS. So somewhere between 10 to 20% of the women with PCOS would be classified as lean according to the BMI criteria. So are they different in terms of their pathogenesis? Is the diagnostic criteria different in them? What is the clinical manifestations? How do they present and what are the outcomes? And do they differ in management is what I'll be addressing in the subsequent slides. Part of the confusion that results when you look at the literature about lean versus obese PCOS is how is obesity defined, or how is obesity defined according for that study. Of course, the WHO, the World Health Organization, has said that in the Asia Pacific region, overweight is, let me just turn the laser on, yeah. So overweight is 23 to 25 BMI and obese is more than 25 BMI. Whereas in the Caucasian population, 25 to 30 is considered overweight and more than 30 only is considered obese. So again, when you look at this, when you look at various sort of research articles, various studies, we have to see what type of BMI criteria that they used. But one more thing we need to keep in mind, particularly for our Indian population, is that obesity, particularly abdominal obesity, is also defined as a waist circumference more than 80 centimeters for women and more than 90 centimeters for men. And you may have a waist circumference which is increased, which puts you into the category of having abdominal obesity, but your weight may be normal according to the BMI. So even when you have just an increased waist circumference, obviously it is associated with increased risk of other clinical problems. And particularly in this respect, I would say that it increases the insulin resistance and increases the tendency towards PCOS. So if we just go by the BMI, we'll be missing a large category of people who have increased abdominal adiposity. In fact, in our clinic, once we've started measuring waist circumference, I would say less than 5 to 10% of our women have a waist circumference which is less than 80 centimeters. So it seems to be a near universal phenomenon that we are seeing, abdominal obesity, particularly in urban areas, both among men and women. So this is important to keep in mind because this increase in abdominal obesity leads to insulin resistance. So if you look at the studies, they've used differing criteria, either based on BMI, less than 25, more than 25, even within the South Asian population. Some studies have used 25 criteria. Some have used the overweight criteria, 23 criteria. Some have used the waist circumference according to the Caucasians. Some have used according to the Asians. So just to say, when you look at the literature, sort of the data that comes up is all over the place. And it is important that you go back and look at how exactly did they define, whether they were saying overweight, whether they were saying obesity, did they use BMI, did they use waist circumference? So I wanted to spend a couple of minutes talking about insulin resistance. Both Shaini and Supraja spoke a lot about how this impacts upon various clinical manifestations. But at the core of it, what exactly is insulin resistance? So insulin receptors are present on every single cell in our body. There is no cell in our body which does not have insulin receptor. Once the insulin binds to the insulin receptor, it sets in place a lot of intracellular cascading signaling pathways. The most important among which are what is called the PI3 kinase pathway and the MAP kinase pathway. Why I'm mentioning these two names is because the PI3 kinase pathway is the one that is responsible for the action of insulin that we are most likely to think about, which is pushing the glucose inside the cell so that it reduces the blood glucose level. However, the MAP kinase pathway is the one that is responsible for cell growth and differentiation. Because insulin is an anabolic hormone, it signals to our body that there is enough and more energy available so you can grow. When you don't have enough energy, your body will try and shut down this anabolic pathway so that there is no cell growth and differentiation. So this is signaled by this pathway, the MAP kinase pathway. Obviously, there is a lot of overlap, but what is important to keep in mind is when we talk about insulin resistance, this is not a uniform insulin resistance, a sort of a differential insulin resistance. The PI3 kinase pathway does not work well. The pathway that is responsible for glucose uptake or the triglyceride lowering, so that pathway does not work, which is why we see a lot of dysglycemia and hypertriglyceridemia. But on the other hand, the MAP kinase pathway, in fact, works too well, which is why there is excessive steroidogenesis, for example, in the adrenal cells or in the ovarian cells, leading to excess androgen production. And of course, because the insulin cannot work properly in the PI3 kinase pathway, the body makes more insulin in an attempt to overcome that insulin resistance. But most of that insulin lands up stimulating the other pathway, the MAP3 kinase pathway. And this is important to keep in mind when we are considering other sort of aspects of or other outcomes of the insulin resistance. One of the talks that's going to follow is about certain malignancies that may arise in PCOS. And potentially the insulin resistance working through the MAP3 kinase pathway is one of the reasons for the increased chance of malignancies. But what we need to keep in mind is that both obese and lean girls can develop insulin resistance. So why does obesity actually increase insulin resistance? We all know that obesity increases insulin resistance, but when you get down to the core of it, why does it? Again, this is an extreme oversimplification, but it's helpful conceptually to think about this. So all of the fat stores in our body produce a lot of these inflammatory cytokines. And because of these inflammatory cytokines, there is inhibition of the MAP kinase pathway, which causes, and the PI3 kinase signaling pathway, which causes insulin resistance. So this is very directly related to the amount of adipose tissue that is present in our body. So one is the amount of fat. The other is the distribution of fat. So, for example, fat which is present in areas where it is not supposed to be present. So, for example, ectopic fat in the liver, ectopic fat in the pancreas, ectopic fat in the heart. So ectopic fat causes a lot of this inflammatory signaling pathway, and this causes insulin resistance. But if you look at lean PCOS girls also, they also have insulin resistance. So this is a HOMA-IR of a lean PCOS girl, and you can see that it is on an average higher than a girl who is a lean control who does not have PCOS. So why would lean girls develop PCOS? So this is something that Shaini was talking about a little bit in her talk. It's a combination of factors. Obviously, genetics and epigenetics plays a role in both lean and obese PCOS. All of the factors listed here play a role in both lean and obese. But to point out that lean girls also develop insulin resistance, probably also because of exposure to endocrine disrupting chemicals, circadian misalignment, not sleeping properly at night, exposure to light at night. And because of all of this, altered appetite, eating at the wrong time, excess visceral adiposity, which is not surprising that thin girls also develop insulin resistance, predominantly because of this visceral adiposity and increased waist circumference. One of the other factors that we need to keep in mind, because we are seeing an explosion of insulin resistance metabolic syndrome in our country, partly maybe because of this, the effect of developmental programming. So maternal undernutrition leads to the fetus being prepared for scarcity after birth. However, after birth, if it is exposed to nutritional abundance, the child then goes on to develop insulin resistance, and because of that, dyslipidemia and obesity and diabetes. So conceptually, if you think about it, the reason for developing PCOS in the prenatal period, it can be because of, if the mother has PCOS, because of that AMH excess, because of this developmental programming, if the child, if the fetus develops SGA or IUGR, exposure to endocrine disruptors, both prenatally and postnatally, and of course the effect of androgen excess. So all this means that the child at birth is primed to develop PCOS. On top of that, after birth, if they develop insulin resistance and abdominal obesity, because of a combination of all of the factors that I mentioned earlier, circadian misalignment, exposure to more EDCs after birth, weight gain, lack of exercise, poor diet. So this further adds to this priming that has already occurred, and this insulin resistance and obesity then gives rise to manifestation of the PCOS phenotype. So it is important to keep in mind that obese, so this is a normal obese. So a normal obese will have reduced insulin sensitivity or more insulin resistance as compared to a normal lean person. But a PCOS lean person will also have that same amount of insulin resistance. And on top of that, a PCOS obese woman will have even more of an insulin resistance. So insulin resistance is the key that links both lean and obese PCOS. And again, one more thing to keep in mind is that it does not take a lot to develop insulin resistance. So for example, young lean girls who have a BMI as low as say 21 or 22, even if they gain about 4 to 5 kilos of weight around the abdominal area, this is typically what we see either when they are in college or when they transition from college into work. When they start working, they live away from home for the first time, they start eating a lot more junk food, they start gaining this excess weight around the abdominal area, and that is when the PCOS, the insulin resistance flares up and the PCOS comes to the fore. So even a little bit of weight gain can significantly aggravate the insulin resistance and tendency towards PCOS. Also, interestingly, there have been studies done showing that PCOS itself can cause obesity. For example, it has been shown that PCOS girls have reduction in their postprandial thermogenesis. So normally after we eat, our body has to have a higher temperature. But this rise in temperature is reduced in girls with PCOS, which means that we are more likely to continue to gain weight once we've developed that insulin resistance and that tendency towards PCOS. So this may further aggravate the problem and perpetuate it. Are there differences in clinical presentation between lean and obese PCOS? This was a study, I tried to look for Indian studies. This was a study which was published about 10 years ago, 14 years ago from India. And what it showed was that the prevalence of metabolic complications was more in obese versus lean PCOS. For example, hypertension was more common in obese PCOS. As expected, dysglycemia was more common in obese PCOS. A thin endometrium was less likely. This is a thin endometrium. So thin endometrium was less likely in obese PCOS. Again, that makes sense because the adipose tissue is the one that's going to make estrogen. So obese women were more likely to have thickened endometrium on an ultrasound scan. And menstrual cycle abnormalities were also more common in the obese PCOS group in this study. A more recent study that came out about 10 years back, where they classified lean versus obese PCOS as a lean less than 23 and obese more than 23, also showed that 83% of the lean PCOS women had insulin resistance as compared to 93% of overweight PCOS, so not necessarily obese, but just overweight. So you can see that a significant percentage of the lean PCOS also had insulin resistance. They also had the obese group were more likely to have dyslipidemia. A third of the women in the obese group had dyslipidemia. About 14% of women in the lean PCOS group also had dyslipidemia. However, the blood sugars were pretty equal in both the groups. So dysglycemia per se was not evident. So it is important that we look for features of insulin resistance, whether you calculate it by using a HOMA-IR or you do a lipid profile or you check a HbA1c or you look at other parameters of insulin resistance. If you just go by the blood sugar, sometimes you may miss this tendency towards insulin resistance that can occur even in lean PCOS. A more recent study, this study showed that the androgen levels was equal in both the lean and the overweight PCOS groups. This study, which was published most recently at just a few months back from India, again showed acanthosis was far more common in the obese PCOS group as compared to the lean PCOS group. HOMA-IR, the marker of insulin resistance, was much higher in the obese PCOS compared to the lean PCOS group. So I think basically what the studies are telling us is that insulin resistance is a feature of both lean and obese PCOS. But clinical presentation and androgen levels are very varied, depending on the type of criteria you're using, whether you're using an overweight BMI category, obese BMI category, depending on how it is, depending on the population that is studied, the age group of the patient that is studied, depending on why they are presenting. Are they presenting because of infertility? Are they presenting at a younger age because of irregular period? That obviously the clinical presentation varies depending on the type of population that is studied. But what is common is the presence of insulin resistance among both lean and obese PCOS. Another place where it makes a big difference is in obstetrics. Obese PCOS increases the risk of cesarean delivery and chorioamnionitis and reduced chances of vaginal delivery. That you're going to have a whole talk on it. So quickly, I'll go through this. In assisted reproduction, obese women do worse. Oocytes which were retrieved were less in the obese PCOS group in this particular study. There was lower implantation rate and lower birth rate in the obese PCOS, and no significant differences in live birth rates in this particular study. But clinical pregnancy rates were less in the obese group as compared to the lean PCOS group. So obstetric outcomes in general, particularly with assisted reproduction, tends to be worse in the obese PCOS group. It makes no difference to the diagnosis of PCOS. We still go through the usual criteria. We go through whether there is presence of hyperandrogenism, oligo or anovulation, whether, and make sure that we've excluded thyroid problems and hyperprolactinemia, and if necessary, CAH. And we look at the ultrasound to see if there is a PCO morphology. So we use the same criteria to make the diagnosis of PCOS. BMI, like I said earlier, is not a differentiating factor, but keep in mind, like I said, in the various studies I presented, lean PCOS is also insulin resistant. So look at the same parameters. Check their blood sugar, maybe a GTT, lipid profile, liver function test. Do they have fatty liver? Check their blood pressure. Check uric acid. Uric acid tends to go up with insulin resistance. So these are all factors you would look at to see whether you can make out that they have insulin resistance. Does management vary between lean and obese PCOS? Not really. The management is the same. Whether we're going to trying to regularize the menstrual cycles or treat their skin or metabolic, emotional, fertility. So the management issues remain the same. Metformin can be used in both lean and obese PCOS. It's obviously particularly helpful in the presence of dysglycemia. But whether or not there is presence of, irrespective of their body weight, irrespective of their BMI, we have to consider using metformin if there is evidence of insulin resistance. The other thing I do want to point out is that oral contraceptive pills, which are used quite commonly in the management of PCOS, of course, we can use it in both an obese and lean PCOS. However, be aware that obesity may be an independent risk factor for certain side effects with the combined OC pills. Particularly obese women or obese young girls may be more likely to have high triglycerides at baseline or elevated liver function test due to fatty liver at baseline. Thereby, obesity may be an independent risk factor for certain of the side effects with the COCs. So make sure that we've evaluated this before putting them on long-term combined oral contraceptive pills. So to summarize, lean and obese PCOS is not really different if you look at it from the aspect of insulin resistance. PCOS is anyhow a very heterogeneous disorder in its presentation. Insulin resistance is a cardinal feature of PCOS in both lean and obese. But keep in mind that again, the insulin resistance varies. You will have some lean PCOS girls with extreme degrees of insulin resistance and some obese PCOS girls with very mild degrees of insulin resistance. But insulin resistance will be a feature in both lean and obese PCOS. Management of insulin resistance always helps. Lifestyle changes, whatever we do, is mainly to help to reduce that insulin resistance. Of course, obesity further aggravates the insulin resistance and tendency towards dysglycemia and poorer outcomes after IVF and pregnancy. I'll stop here and thank you very much.
Thanks a lot, dear Jayashree, for throwing light on the metabolic risk factors in obese and non-obese PCOS. It was very enlightening. Thank you very much.
Thanks, Shani. Karpadam, you're on mute.
Sahiti, can you please show Dr. Siddhartha's slide? Yeah. Fatima ma'am, you can introduce.
Yes. I'd like to welcome Dr. N. Siddhartha. He is the Associate Professor in the Department of Reproductive Medicine and SRNC. And he's done his MBBS from the Narayana Medical College, Nellore. He's done his MS OB-GYN from Jain Medical College, Belgaum, and MCH in Reproductive Medicine and SRNC. And he's presented more than 13 conference papers have been presented. He's participated as faculty in 13 state-level conferences, 6 national and 4 international conferences. He has done various publications in various journals. I call him to give a talk regarding the induction stimulation of the ovaries in case of PCOS, which is really a challenge for most of the obstetricians. And I hand over the mic to him, Dr. Siddhartha.
Thank you very much for the kind introduction, ma'am. Can I share my screen? Yeah.
Yes, please. Yes. Yeah. On slideshow mode, please.
Yeah.
Yeah. Okay. Ready. Yes.
So basically today, I thank Dr. Kundavi ma'am and others for giving me this opportunity. Is my voice clear, ma'am?
Siddhartha? Yes.
Is my voice clear, ma'am? Yeah, thanks.
Yes, yes. Yeah.
So today I'm going to discuss about the stimulation strategies in resistant PCO in an evidence-based approach. So we all see this. Yeah, we all know what is a resistant PCOS, but for definition, it's failure of ovulation after 6 cycles of clomiphene citrate, reaching a dose of 150 milligrams daily. And this is seen in 15% of PCOS patients. And resistance is not only clomiphene resistance, as we all have been listening to this definition for quite a long time. Resistance can be with any, it can be CC resistance, it can be less commonly though, letrozole resistance, or it can be a resistance to gonadotropin. So how much ever, I hope you all must have seen, and the cases which we have given even 150 to 225 international units of gonadotropins, FSH or HMG, but they never had any follicle. So how do we go about systematically in such cases is the crux of my talk today. So we need to understand first what is resistance. It's not just like number, like you do 1 cycle or 2 cycles or 3 cycles or 6 cycles, whatever the definition says. This is not a number. So this is something more than a number. We need to understand why the resistance occurs, the pathophysiology. So one is insulin resistance. So PCOS women, we all know they have insulin resistance. So these IL-1 receptors are also there on the follicle. And they have hyperandrogenemia and they have obesity. And some people are having genetic predisposition, that is polymorphisms. So, so how to go about, I'm going to discuss this. So first of all, the management strategies are broadly like, first, correction of insulin resistance. So we need to give metformin, we can give myonisol decanoinositol, we can ask the lady to reduce weight, and even 5 to 10% of reduction in body weight will improve the chance of ovulation pregnancy rates. And hyperandrogenemia can be clinical or biochemical. Normally, we tend to miss out biochemical hyperandrogenism because the lady must have been using some hair removal methods, and the hyperandrogenism as such may not be clinically evident. So then we need to do the total testosterone and just look for the biochemical hyperandrogenism, where in the clinical hyperandrogenism is not so obvious. So any testosterone level more than 76 nanogram per deciliter or 0.76 nanogram per ml in the reproductive age lady is abnormal, and we need to evaluate her further. So obesity, as I've already told, should ask the woman to reduce body weight, and rarely genetic predisposition like FSH and LH receptor polymorphisms. So wherein the lady can require a little higher dose, and this is more important in IVF rather than non-ART based therapies. So now, so how specifically we need to target by medical management? So we can keep other options later, ART or surgical management like ovarian later. So medically, so these patients who have clomiphene resistance will immediately, we can start metformin. We can start metformin at a dose of 1,500 to 2,000 milligrams per day. We can't start with a higher dose. We should start with a low dose and gradually increase. So once the lady is adequately sensitized, because insulin resistance is not something which is expressed in terms of abnormal OGTT. Because if you want to diagnose insulin resistance in a PCOS lady, we need to examine her clinically, look for acanthosis, look for her any excessive weight gain recently, and we need to do something called HOMA-IR, like fasting glucose insulin. If you put in the software, you get HOMA-IR quickie. That is the accurate method. So just by saying that OGTT is normal, it doesn't mean that there is no insulin resistance, because we have been taught for age old that if the OGTT is abnormal, that is the indication of metformin. It is not so in the present era. So once lady sensitized, then we can start with the following therapies. You can add clomiphene and letrozole. We can do this clomiphene and letrozole in the increasing doses called stair-step protocol, and we can do a combination protocol combining clomiphene and letrozole, and we can do an extended regimen, which I'm going to discuss. An addition of low-dose HCG has been proven to be of benefit. Addition of dexamethasone, this is again of two types. Dexamethasone can be a low-dose dexamethasone chronic therapy, or it can be a dexamethasone during the ovarian stimulation. And addition of bromocriptine in case of hyperprolactinemia, which can be associated in PCOS, and the pre-treatment suppression with OC pills for 2 to 3 cycles. In case there is increased LH. And if the OC pills are, the woman didn't respond to OC pills, there are other methods like GnRH agonist or GnRH antagonist, which I'm going to discuss. So as I've already told about insulin sensitizing agents, and I've already told about combination therapy, and we can also combine the oral agents with gonadotropin so that the response can be faster and the expense of prolonged administration of gonadotropin can be less. And that's what we call a sequential regimen. And at the last, laparoscopic ovarian drilling in very selective cases. And the first, of course, is aggressive weight loss, which I've already told. So it has been shown in the studies that instead of giving a high dose for a longer period, the clomiphene citrate can be given at a 100 milligram dose, because we all know that when we increase the dose of clomiphene citrate from 100 to 150, there's a very less number of patients who are going to ovulate, who are not going to ovulate with 100. So what they have seen is, if you give clomiphene for 10 days instead of 5 days, at a lower dose though, like 100 milligrams, the ovulation rates are going to be better, and the pregnancy rates are going to be better. And the endometrial thickness is, of course, not compromised because of anti-estrogenic effect of clomiphene in this study. So the probable reason is the prolonged FSH rise, which will help to cross the threshold. So the other one, which we have popularly, I think many of us would have started using, which has been becoming more and more popular in the recent times, is the stair-step protocol. So initially, the lady used to come with, and we used to give 50 milligrams of clomiphene, and she never used to respond, and start with increase to 100, and then the next month go to 150. So instead of that, it takes almost 3 months here. So instead of that, we can give the same cycle with giving a gap of 5 days and just looking for the response. The lady is unresponsive, increasing the dose by 50. Suppose you start with 50, increase the dose to 100. If it doesn't work with 100, go to 150. So by this, the ovulation rates are markedly reduced depending on how fast the lady is going to respond. It may be from 32 to 53 days, and pregnancy rates are not compromised. That is very interesting. So the ovulation rates are improved and the pregnancy rates are not compromised, because the only concern with clomiphene is the prolonged administration of clomiphene. And if you want to start, if you start with 50, you have to reach to 150. It takes some time. And because of this, any anti-estrogenic effect could reduce the pregnancy rate, was the concern. But studies have proved that there is no such concern. So, and even you can have a stair-step protocol, which is comparable with gonadotropin therapy. So here, one is cost effectiveness. And other thing is, when you give gonadotropins directly, because the lady is resistant to clomiphene citrate or letrozole, the OHSS rates and multiple pregnancy rates are more, the risk can be increased. So it reduces the cost and it increases the safety of the patient. So what is this microdose HCG? So microdose HCG is something, it's something like a cost-cutting strategy, and to some extent it's also sensitizing, it's also a therapeutic approach. So here what is suggested is you can add 200 international units of intramuscular HCG. That's a very low dose. So normally I use in very selective patients. I dilute in a 50 ml of normal saline. I just cool the normal saline bottle 1 day prior, and I'll add 5,000 units of HCG into 50 ml of normal saline. In 100 ml normal saline, I empty half of the bottle and I will mix this HCG, and in some, I use it in ART patients who are not responding despite the maximum dose of gonadotropin, like 300 recombinant FSH in 150 HMG. So in poor responders, to be very specific, I used to use, but it has also been suggested in the PCOS patients that once the dominant follicle reaches 12 mm, so adding this microdose of HCG would help her to reach follicular growth faster, and it is more cost effective. It has been suggested by some in one study. So other one is metformin, which I have already discussed. So it lowers how it acts. It lowers the androgen production in the TCA cells. And there's one pathway in PCOS like P450C17, wherein they say that 17 alpha hydroxylase and 1720 ligase and overexpression of these enzymes will cause hyperandrogenism. So this part of the component of the PCOS hyperandrogenism is taken care of by metformin. And of course, it prevents premature follicular atresia, and thereby it has got higher rates of ovulation, clinical pregnancy, and live birth compared to placebo. And the combination of CC and metformin is also is shown to have a benefit compared to CC alone, especially in clomiphene-resistant PCOS. So now, what is this myoinositol? So some patients are not tolerating to metformin because we know the side effects of metformin. They cause severe GI disturbances, and patient almost will be non-compliant, especially when you start them or when you increase the dose faster. So there are 3 meta-analyses and 8 RCTs and one non-randomized trial, and they compared the effect of myoinositol and metformin, and they are found to have a similar benefit in terms of clinical, hormonal, and biochemical profile. So it can be an alternative, and it has a safety profile is well documented, and potential there's a potential role of myoinositol and D-chiroinositol combination in the management of resistant PCOS. So apart from that, there's also a role of CoQ10 and in combination with clomiphene citrate, wherein they have found there's a better endometrial thickness, increased ovulation rate compared to 15 compared to 65.9%, and better clinical pregnancy rate. So probably it acts by directly on the mitochondria, and it reduces oxidative stress, and it's considered should be considered before gonadotropin therapy or more aggressive therapies like ovarian drilling. And we all know that N-acetylcysteine is also very well known. It has been used by by many of us with some benefits. And so suppose the lady is clomiphene resistant for what is the next line of management? So this happened only when in the era where the clomiphene was the first line of drug used in PCOS. Now with the international guidelines coming, which have come in place in 2018, now we all know that letrozole is the first line drug, and letrozole and I can also use anastrozole. They are comparable, and the endometrial thickness at the time of HCG was significantly more than anastrozole group though, and the duration to reach dominant follicles was so anastrozole is little more potent, but practically both are one and the same, and we commonly use letrozole rather than anastrozole. So if you compare this letrozole to ovarian drilling, the ovulation rates are higher in the letrozole in one study, and the endometrial thickness is better, and the pregnancy rate also was a little bit higher in letrozole group compared to ovarian drilling. So first we need to try letrozole compared to directly going for ovarian drilling, because ovarian drilling is not a one-time solution. It's only a temporary solution. So again, the woman is going to come back with some resistance. So we can advise her some insulin sensitizing drugs like myoinositol or metformin, and advise her weight loss, and probably then start letrozole. And even you can combine letrozole with, as I said, with metformin, and it works out well in obese PCOS. And even we can extend letrozole therapy, and even we can do a stage step with letrozole therapy. So all the advantages are there equally with letrozole, as I have told with clomiphene citrate. So with stage step, you can go up to 10 milligrams of letrozole that's the maximum dose where you can go. So comparing letrozole and clomiphene citrate, in a low, the BMI is less than 30.3, the live birth rates were similar, but when the high BMI in obese PCOS patients, letrozole is better. But there's no such confusion now because this study is written in 2014, because the international guidelines saying letrozole is the first line, there's no confusion. We probably have to go with letrozole therapy. Comparing letrozole with tamoxifen, letrozole was found to be superior in terms of ovulation, pregnancy rates, and even the side effect profile. So now dexamethasone. So dexamethasone, when there's a rationale to use dexamethasone as therapy, not as an adjuvant. So normally we tend to use it as an adjuvant in clomiphene-resistant PCOS. But to clarify this before, we tend to use dexamethasone as a therapy only when there's a functional adrenal hyperaneurysm, which can occur in 25% of PCOS patients. So the 25% of PCOS patients have functional adrenal hyperaneurysm, and these patients require dexamethasone. So dexamethasone can be given in a very low dose of 0.25 milligrams over a period of 3 months, and especially when these patients have a high DHEAS. Now, compared to clomiphene-resistant PCOS, what is the role of dexamethasone in clomiphene-resistant PCOS? So we don't give continuously over 3 months and then start ovulation induction as in a functional adrenal hyperaneurysm, which I said, which can occur in 25% of PCOS. We give dexamethasone in a dose of 2 milligrams starting from day 3 for 10 days. And this is known to improve the ovulation by suppression of hyperaneurysm transiently, and has got some synergistic actions with FSH, and there are indirect effects on the intrafollicular growth factors and cytokines. So what if the ladies, not even responding to clomiphene, not responding even letrozole, and with all these adjuvants? So what specifically do when there's letrozole resistance? Because first you try clomiphene, so she doesn't respond, then you go for letrozole. Even that there is a no with letrozole therapy, then what next? So we can do a long letrozole therapy. We can give letrozole same dose for 10 days, or we can do a stage step, which I have told. So stage step starts with a 2.5 milligrams, and we can gradually increase it as we are doing with clomiphene. Especially, we can this helps when the AMH is more, and some people even say directly start with a higher dose of letrozole when the AMH is more than 4.5 nanograms per ml. So we can go at the maximum of 10 milligrams of letrozole stage step. So patients achieved a comparable ovulation in clinical pregnancy rates, and time to ovulation was shorter with letrozole therapy. And we can give even a combination regimen, CC and letrozole, 5 milligram letrozole with 100 milligram clomiphene citrate. And even I tend to increase the letrozole to 7.5 milligrams. The patient is not affordable for gonadotropins. And even I tend to extend the therapy from 5 days to 7 days or even to 10 days. And it has worked good, though in selective cases, it has worked good for me. So when you compare letrozole plus metformin and laparoscopic ovarian drilling, so there is a significant reduction in testosterone levels with ovarian fasting insulin and fasting glucose insulin ratio in metformin plus letrozole, and there's no significant difference in cycle regularity, ovulation. So what you mean to say is they're almost comparable. So letrozole and ovarian drilling are comparable. So, but only thing what we need to understand is we need to try a safer thing first, not directly go to ovarian drilling. Gone are the days where we in the PCOS, we directly, when the patient is not responding, we drill them. So there's one more alternative, a safer alternative rather, to ovarian drilling, which has been suggested, wherein we do just like oocyte retrieval with a 16 gauge 35 centimeters needle. We just do 3 to 6 punctures in a ovary which is unstimulated. So it's an outpatient office procedure, and it can be accomplished with a very mild sedation. You don't require a GA for that, and the costs are reduced, and the safety is better than ovarian drilling. So this can be tried as an alternative to ovarian drilling. And what is whenever you want to go with all these oral ovulogins and all the combinations and all the adjuvants failed. So before ovarian drilling, we invariably go with a chronic low dose step up regimen in the PCOS. So conventional step up starts with 75 international units of gonadotropins, and we step up every 5 days by seeing the response. Because this can create some kind of a OHSS in a PCOS patient. So what in a PCOS patient we tend to do is a chronic low dose step up, wherein we can start with a half ampoule or 37.5 international units and not step up for the first time till 14 days. And then every 7 days, we can increase, we can step up by every half an ampoule. So, or if you have a pen, you can step up by 25 international units, and we're giving a recombinant FSH, but we generally do avoid that in a PCOS because of cost constraints. So the trigger criteria is going to be same. And this chronic low dose step up therapy in PCOS So it has shown to have less incidence of OHSS, and the chance of ovulation pregnancy rates are better. So there's something called PrAP therapy, that's pulse rhythmic administration of ovulation induction in PCOS, wherein it's something like a combination therapy, but little modified version. So this is has been formulated to allow ovulation induction with a like a combination therapy, but at the same time avoiding OHSS. So we start with letrozole, 2.5 to 5 milligrams, and give FSH on 3, 6, and 8. And you see the check for the lead follicle on day 9. If there is no lead, if the lead follicle is more than 10 mm, we can continue with the same dose. Otherwise, we need to increase the dose by one. Otherwise, we need to increase the dose if there is no follicle to 150. And if there is no dominant follicle by day 16, we have to cancel the cycle. And the next dose, the initial dose only should be 150. So here we start as a combination therapy and give on 3, 6, and 8. And we can even go every alternate day or daily if there's no dominant follicle by day 9. And if there is no dominant follicle by day 16, the first cycle, we tend to cancel the second. Second cycle, we start with 150. And we can go up to 225. So this will ensure that lower amount of gonadotropin is consumed, because the problem with the chronic low-dose therapy is increased amount of gonadotropin consumption. So that can be avoided in this PrAP therapy. So what if there is FSH resistance? So even if you try gonadotropins and there is resistance, then we need to think about polymorphisms. Because when you're thinking about the monofollicular development, you don't have to think about much about polymorphism. But this polymorphism discussion will go more in the ART rather than PCOS for IUI. So we can only thing is we have to increase the dose of FSH, and we need to add LH. And if at all you think that patient is having a polymorphism, or if the patient is proven to have a polymorphism, you can directly give HMG instead of recommended FSH or recommended LH in IUI cycles. It is more cost effective. So, and finally, if everything fails, then before going to ART, the woman is young, lean patient, and LH is elevated. In such patients, probably we can we can try laparoscopic ovarian drilling. So we have to follow the rule of 4, and if the volume of ovary is more, we may have to put more punctures, but it should be like 40 millimeters, 40 watts current and 4 punctures. So not more than that. It should be very carefully done. So it's not totally contraindicated, but should be highly selective. So apart from laparoscopic ovarian drilling, we can also put the lady on metformin, and we can also add recombinant FSH. Though it is very costly, we can replace that with HMG. So ultimately, the combination therapy with letrozole and CC in clomiphene resistance, that this I've already discussed. So it is known to increase the ovulation and pregnancy rates and mean duration of treatment. So now what is the combination therapy which we are using? So we can use letrozole and CC combination. We can use letrozole and HMG, and we can use CC plus HMG, and we can use HMG alone. Now with the HMG alone, what is the therapy which we have discussed is the chronic low-dose step-up. The consumption of the gonadotropin is high. That is the only problem. And CC and letrozole I have already discussed. If that doesn't work out, we can either give letrozole plus HMG or CC plus HMG. So letrozole, because it's a first-line drug, we can combine that with HMG. So this has got a better shortened time to ovulation, improved pregnancy. So instead of going directly with HMG, we can add letrozole with HMG. So this reduces the risk of hyperstimulation and also decreased consumption of gonadotropins. So IVF, ET, and IVM, these are even if the IVF, there are some PCOS patients, though very rarely, they don't respond even to ovarian stimulation. So probably in them, we have to go with IVM. So that's very rare though. So the last resort practically for all this clomiphene PCOS or consuming more and more drugs every cycle, patient is not happy. So patient can tell, instead of that, she may ask her to give one-time solution. Very rarely though, we may have to go for IVF. So there are many protocols in IVF, and this is not the scope of discussion for today. So we all know that antagonist protocol with agonist trigger is safe in PCOS to avoid OHSS. So bariatric surgery is experimental, and we can consider the BMI is more than 35 kilograms per meter square, and the patient should not conceive for at least 1.5 years following bariatric surgery, at least 1 year. So that is the limitation. So we need to cover proper counseling is required. So if they're in a very high BMI patient, not consuming all the therapies, maybe bariatric surgery can help. So in summary, it is extended CC regimen or a state step protocol for a clomiphene-resistant PCOS with insulin sensitizers like metformin and myoinositol. And letrozole is the present first-line drug. And we can add dexamethasone, there's no functional adrenal hyperandrogenism, only a short-term dexamethasone 2 milligram administration from day 3 to day 10 is okay. And a low-dose HCG and NSA-assisting CoQ are other adjuvants which merits a consideration. And receptor polymorphisms, they're more of to be considered in a ART cycle. And the last should be laparoscopic ovarian drilling, and the very last should be IVF in a clomiphene-resistant PCOS. And very rarely we tend to do IVF in such patients. Thank you very much.
Thank you, Dr. Siddharth, for this enlightening speech on you had told many things regarding microdose HCQ, microdose HCG, PCQ versus letrozole, along letrozole therapy, star step therapy, PrAP therapy, FSH resistance, and regarding the receptor polymorphism, and regarding all the combination regimens which can be given in case of resistant cases, and how do we prevent hyperstimulation when we give higher doses, and also regarding vaginal drilling and also IVF. So thank you very much, Dr. Siddharth, for this enlightening talk.
Thank you very much.
We know that PCOS girls and women are with us during the adolescent and adult periods for menstrual problems and later for infertility. But then PCOS does not stop with that. It casts its shadow even in the advanced stage. So to know about the cancer risk in PCOS women, we are really blessed to have Dr. Lakshmi Seshadri, whose books are really very popular among undergraduates and postgraduates. She's former professor and HOD, CMC, Department of OBGYN, CMC Vellore, former senior consultant OBGYN, Tirumala Mission Hospital, Ranipet. She has more than 50 index journals, and her textbooks, as I said, are very, very popular, very comprehensive, and she has been awarded several orations in various conferences. Her areas of interest being gynec oncology and menopausal medicine. She's been doing great community work in the field of screening for cervical cancer with PAYA and screening and management of NCDs in a rural population. Really very commendable. Madam, please.
Thank you. Thank you. Can I just...
Madam, you're muted, madam.
Am I? No, here I have unmuted.
Heard, madam.
Yeah.
Okay, can you hear me now?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Okay. Why am I not able to get
Slideshow.
Slideshow.
F5 போட்டுருங்க madam. F5.
Sorry?
F5.
F5, huh? F5.
Yeah. அங்க மேல front functional keys இருக்குல்லுங்க madam. அதுல F5 போட்டுருங்க.
அது என்னமோ இன்னைக்கு அப்பல இருந்து எனக்கு தகராறு பண்ணிட்டு இருக்கு.
சரி கீழ இருக்குல்லைங்க madam. கீழ இருக்குல்லைங்க madam. அந்த இது
கீழ நான் பண்ணி பார்த்தேன். வந்துடுது. Okay. Fine. Okay. Are you able to hear me now?
Yes, yes, yes.
Yes, okay. We have been talking today for the last 2 hours about PCOS and its various presentations, complications, and management. I think one aspect of polycystic ovarian syndrome that has received a lot of attention recently is increase in the cancer risk in women with polycystic ovarian syndrome. And let's see if there is any association and what is the evidence for it. Association of polycystic ovarian syndrome with endometrial cancer seems undisputable. association with other cancers are inconsistent in various studies, and the studies lack sample size or well-defined diagnostic criteria. This has been the major problem you will see with any kind of study with polycystic ovarian syndrome, because people don't adhere to the criteria of a definition or diagnosis of polycystic ovarian syndrome, because any any ovary with a few cysts is taken as polycystic. Many of these studies actually also have self-reported diagnosis of polycystic ovarian syndrome. They even have said that, yes, I have had it in the past, and then they have looked at cancer risks, and therefore the results have been quite inconsistent. But let's anyway have a look at it. Recently, that is in 2019, there is a Swedish data that was published, which I think kind of made people sit up and look at this association of PCOS with cancer and with cancer in general. And then people went back and looked at various other studies that have been published in the past. You can see that this particular study was performed on 34 lakhs women aged 15 to 50 years, of whom about 14,500 or so had polycystic ovarian syndrome, and among these 182 had primary cancers. We are only looking at primary cancers. They found that there is an overall increase in the risk. The hazard ratio was 1.15. It's a little more than 1. So if when you look at the overall increase in the cancer risk, it is just slightly above 1. But if you look at the individual cancers, endometrial cancer was 2.6. Ovarian cancer, the hazard ratio is 2.1. If you look at cancer of the other endocrine glands, it was almost 2. Pancreatic cancer, strangely, was 3.4. Renal cancers was 3.07, and skeletal and hemopoietic system cancers are 1.7. So all these cancers have a hazard ratio which is above 1. The risk is higher when you look at premenopausal women. You find that the overall risk was 1.2, but the endometrial cancer risk hazard ratio was 6.4, ovary was 2.5, pancreas was a 6.6. What the explanation that is being given for this is that when cancers occur in the younger age group, they are more often related to polycystic ovarian syndrome, whereas those in the older women are related to age and other carcinogenic or other factors that cause cancer, and that is probably why you see them more often in the premenopausal, this association. The same thing as the previous slide, this is what the author has compiled and found that the adjusted hazard ratio was for pancreas was 3.4, endometrial was 2.6, ovary was also increased, kidney, renal cancers and other endocrine cancers were definitely higher. And when they compared pre and post-menopausal women, the cancer risks pre and post, the difference was quite significant. Now, when you look at polycystic ovarian syndrome and gynecological cancers, the association with the endometrial cancer, this association was described in as early as 1947. But with ovarian cancer, they started looking at the association in 1996. That was where it was first reported. And lower breast cancer risk was actually reported in 1991. Subsequently, there have been a whole lot of studies. There are case reports, there are case series, there are case control studies, there are cohort studies, and there have been cross-sectional studies. Now, contradictory evidence, as I already told you, is basically because most of the studies have very small number of cases. The patient selection, there has been a selection bias. As I said, it could be really confirmed polycystic ovarian syndrome, maybe self-reported. They have looked at various other, not all of them have used the Rotterdam criteria for diagnosis, etc. And there have been confounding variables. For instance, obesity, dyslipidemia, metabolic syndrome are all risk factors for many of these cancers. So how many of these cancers were purely due to polycystic ovarian syndrome, how many due to various other factors, we really don't know. Now, there have been 3 important meta-analyses that have been published. As you all know, that when you look for evidence, rather than all this, or when all these have smaller number, to combine them and put them up as meta-analysis actually gives you better results. And so the Three well-known meta-analyses, one by Chittenden and Associates, Hale and others, and Barry and Associates. If you look at their reports, Chittenden and Associates had looked at endometrial cancer in some case control and one cross-sectional retrospective study, and all of them showed a very definite association. The relative risk is increased more than one. Ovarian cancer, there was only one study in the meta-analysis and it showed an increase in the risk. Breast cancer actually showed a decrease in the risk. That anything less than one relative risk or odds ratio, you know that the risk is less than in the general population. Howler and Associates actually presented their series on endometrial cancer and definitely found an increase in the risk. Barry and Associates, very often quoted study, they looked at few case control and other studies and found that with endometrial cancer, the risk was increased. Ovarian cancer, the risk was increased marginally in one and 2.5 in the other. And with breast cancer, the risk was definitely reduced. So the increase in cancer risk in polycystic ovarian syndrome may be due to associated diabetes, dyslipidemia, unopposed estrogen, hyperandrogenism, hyperinsulinism. We've been talking about all this time and time again in the previous lectures. And in addition to all this, there is also a state of chronic inflammation in polycystic ovarian syndrome, which may affect any of the organ system and lead to a malignancy. The other 5 factors involved are smoking, alcohol, and family history. And of course, interventions like combined oral contraceptive pills, metformin, many of them may also be associated with cancers. We really don't know. So when you look at cancer risk, it has to be in the light of all this. You need to be aware that all these are factors that can lead to cancer, and it can't be polycystic ovarian syndrome alone, even though the syndrome consists of a combination of all this as well. So let us look at the endometrial cancer risk. Endometrial hyperplasia and cancer caused by multiple factors in PCOS. The clinical features are all this. We've looked at it time and time again today. All are risk factors for endometrial cancer. And there's increase in adrenal and ovarian androgen synthesis caused by hyperinsulinemia. There's conversion of androgens to estrogen by the adipocytes. There's upregulation of aromatase action. There's low circulating progesterone, which actually protects the endometrium. And there is increase in the IGF-1 levels. And basically, this is what happens. So all the factors that we just talked about lead to hyperinsulinemia. There is decrease in the sex hormone binding globulin. There's increase in ovarian androgen, etc., etc. All of them causing an increase in the IGF-1, and they lead to endometrial proliferation. Now, there are 2 systematic reviews, 3 meta-analysis, and 5 individual studies, and all of them have been compiled by Chaitra and Associates and published very, very recently. The odds ratio for endometrial cancer in women with PCOS was unmistakably increased. The risk was 2.89, which means that women with polycystic ovarian syndrome have a 3 times more risk of developing an endometrial cancer compared to general population. Now, this translates to a 9% lifetime risk. Undiagnosed polycystic ovarian syndrome has a higher risk, basically because when the disease is undiagnosed, there is no treatment for the hyperestrogenism and hyperandrogenism, which are the factors which contribute or increase the risk of cancer. And if these are not treated, the risk of cancer is higher, especially of the endometrium. BMI is a confounder and a mediator, and majority are adenocarcinomas and majority are type 1 cancers. The type 1 cancers are the ones which occur in younger women and are estrogen dependent. But you don't actually see the type 2 later onset endometrial cancers being associated with the PCOS. Now, looking at all the studies that have been listed in that particular, in the meta-analysis, you can see now starting from 1983, people have looked at it, and almost till 2015, the studies have been compiled. And if you look at it, all of them show an odds ratio or a relative risk which is more than 1. So any study that has looked at endometrial carcinoma has found that the risk is certainly increased. There are 2 meta-analyses here included in this, actually 3, and you find that 2.8, 2.9, and 2.7 have been the risk that has been reported. Now, Barry and Associates also looked at endometrial cancer overall risk and in those who are under 54 years old, and they found that whereas the risk was overall risk in the overall risk was about 2.7 odds ratio. If you look at women who are less than 54 years old, the risk is increased further to a relative risk of 4. So the risk is certainly more in younger women who develop cancer, meaning the association is more in younger women who develop cancer than in those who develop cancer much later. So risk of endometrial cancer increase overall, but is higher in younger women. Older women tend to have a type 2 endometrial cancer, which is not associated with PCOS. Variation in the relative risk between studies is due to lack of uniform definition, etc., etc. However, the increase in endometrial cancer risk is absolute and is evident. Now, moving on to endometrial PCOS and ovarian cancer, these are the studies that have been looked at starting from 1994 to 2016, and you find that the overall odds ratio hovers around 1 or a little more than 1, indicating that the risk is slightly increased or maybe not when these have reported 1. And of course, some studies in the earlier years have reported a higher risk, but then the later studies do not show the same kind of increase. So here there is inconsistency. So the ovarian cancer in PCOS is linked to androgen exposure, and the risk of ovarian cancer is increased in women with diabetes, hyperglycemia, hyperinsulinemia, and increase in IGF-1. The increased androgen receptors on ovarian cells in borderline and benign tumors, and many studies show no increase or non-significant increase. Some show a significant association, as I told you. Now again, Barry and Associates looked at this association in younger women under 50 years and looked at overall risk, and they found that the overall risk in their meta-analysis was 1.4, but when they looked at women under 54, which is just one study, the association was a little more. So again, it is the risk is increased in the younger women. So in this meta-analysis, overall increase in risk was 1.4, but the odds ratio was higher and significant in younger women. In women with a cycle length of more than 35 days, that is those with oligomenorrhea, which is what it was called earlier, or infrequent cycles, the risk of borderline serous and mucinous tumors is increased, and risk of other tumors is actually decreased, maybe because of point mutations. Overall, the number of studies are small, results are conflicting, and any increase, if at all, is small. Large case control studies are actually required to confirm this association. Now moving on to polycystic ovarian syndrome and risk of breast cancer, look at the number of studies that have actually looked at it, 1983 to 2015, and almost all of them show a risk that is less than 1, barring a few, but these were cohort. But if you look at the meta-analysis, the risk is just 1, which means that it is more or less the same as in the general population. So the risk, overall risk, if you look at this analysis by Barry and Associates, the meta-analysis does not show an increase in the risk. He actually has an overall odds ratio of 0.9, which is a little less than 1. And in younger women under 54, the risk is 0.78, which is definitely less than 1. So there seems to be a decrease in the risk of breast cancer. Most observational studies, case control studies, and meta-analysis do not reveal an increase in the risk of breast cancer, and women with infertility, anovulatory cycles, and infrequent cycles have a reduced risk, and breast cancer is not a worry in women with polycystic ovarian syndrome. Now, strangely, there have been a increase in the risk of pancreatic and renal cancers that have been reported, as you've seen in my first study that I put up. And much later, in 2022, from Memorial Sloan Kettering, there is a report which says that the relative risk is more certainly increased. Actually, the risk is 1.9, or rather, there is the risk of a pancreatic cancer is doubled in women with polycystic ovarian syndrome. People are looking at the pathophysiology, which is not understood. Now, there are not many, no other study looking at renal cancer and its association. There is an increase in the chronic inflammatory lesions in the kidney, but cancers are barring that study, nobody else has reported an increase in the cancer. Now let's see, why does this happen? Why is this a risk increase? So I just went back to look at the cancer genetics to see whether this can be explained. Most people explain it because of that. There are these genomic alterations. The genes that cause polycystic ovarian syndrome, that is grouped as PRG, and that is genetic alterations or the mutation. The genomic alterations in the non-polycystic ovarian group is PNRG, and if you look at endometrial cancer, ovarian cancer, and breast cancer, you can see that the genomic mutations or alterations are definitely increased in polycystic ovarian cancer group. In all the cancers, the difference is obvious in endometrial cancer, very, very little in ovarian cancer and in breast cancer. And if you look at what genomic alterations are found, you find that in endometrial and breast cancer, it is in the mRNA downregulation genes, and in the ovarian cancer, it is in the CMV amplification. Now, look at these last part of the figure. You find that these are the genes that are overlapping between polycystic ovarian syndrome and endometrial cancer, polycystic ovarian syndrome and ovarian cancer, polycystic ovarian syndrome and breast cancer, and you find that the genes that are commonly seen, that is the genomic alterations, are usually found. These are called the ones for endometrial, ovarian, and breast cancer. All these overlap in polycystic ovarian syndrome and in these cancers, and therefore it can easily be explained as to why the cancer risk is more. Frequency of genomic alterations higher in PCOS related genes compared to non-PCOS related genes, as I showed you in the figure. Most common genomic alteration in endometrial and breast cancers are mRNA downregulation, and in ovarian cancer is gene amplification. Ovarian, breast, and endometrial cancer driver genes are found in PCOS related genes. Now, alteration in the PCOS related genes overlap with the alterations in the ECOC and the breast cancer genes. Look at this. They have identified about 99 genetic genes in which alterations take place, and these are all the ones which overlap. The endometrial cancer and PCOS overlap, endometrial cancer and ovarian cancer overlap, and ovarian cancer and breast cancer overlap. And these are the ones where there are genetic alterations. One may wonder, when there is alterations are present, why the breast cancer alone is less but endometrial cancer is more. Probably because even though there are genetic or genomic alterations, it may not involve the tumor suppressor genes, or the alteration may not be those that promote cancerogenic or cancerous changes. The explanations have not been really worked out. We just know that the genes overlap, and therefore it is eminently possible for women with PCOS to develop gynecological and breast cancers. So we looked at this association. So what are the practical implications? How does it translate it into clinical medicine? We just need to know that women with polycystic ovarian syndrome must be counseled regarding increase in the risk of endometrial and ovarian cancers. The risks increase with other factors like age, BMI, hyperandrogenism, and metabolic syndrome. This places them under the intermediate risk for endometrial cancer. We divide them into low risk, intermediate, and high risk. Advice regarding lifestyle modification, diet, exercises, weight reduction mandatory. Any abnormal bleeding should be evaluated promptly. Routine screening for endometrial cancer is not recommended currently. There is no, just because somebody has a polycystic ovarian syndrome, you don't have to routinely do transvaginal ultrasound or a PIPL biopsy. Ovarian masses in these women should be evaluated thoroughly, but routine screening for ovarian cancer, again, is also not recommended. Thank you very much for your attention. Hello.
Madam, for your excellent talk. You have kindly gone through the data analysis, research evidence to talk about cancers and treatments. So management is extremely important, and should be lifestyle management, should be lifestyle care. Thank you very much, madam.
Thank you. Thanks for your opportunity, and I really enjoyed your webinar today. A lot of things to learn and a lot of take-home messages. Thank you. Thanks.
Thank you so much, ma'am. It was, all the topics were very relevant for PCOS, because we always stick to this irregular periods, infertility, abnormal uterine bleeding. But there is a huge spectrum of clinical symptoms and signs that patients can present with, but physical problems can also happen even without symptoms. So it's very important for us to understand all these things. I just have a question for Dr. Jayashree Gopal. Madam?
Yeah, tell me, Kalpana.
Madam, because what is the relationship in uric acid and this kind of a hyperinsulinemia, madam?
So one of the, I mean, when you say elevated uric acid, one of the things you need to think about is insulin resistance.
Oh, it's like
So
the other
insulin
way around.
resistance causes, insulin resistance causes high uric acid. I'm not talking about levels of like above 8, 8.5. That usually happens because there isn't, some sort of a problem with overproduction, a genetic issue type thing. But the usual values that we tend to see, with a slightly elevated triglyceride, 150, 180, 200, that triglyceride with slight, HbA1c of 6. If you see uric acid will be like 6.9, 7.2, something like that. So that's part and parcel of the same insulin resistance.
So, okay. So, but you don't have to treat that separately, but treat only the insulin resistance part of it. Okay.
Exactly. It will come down with that, yes.
Okay. And one more thing about this non-alcoholic fatty liver disease, which we are coming across in really large population in women who are not very obese, even in young girls. So we see this kind of scan report saying that, is it part of a metabolic syndrome, which is related to polycystic ovaries, madam?
Yes, very much so. So in fact, now they've changed the name. They've called it metabolic syndrome associated fatty liver disease. M for monkey, MAFLD, not NAFLD.
Okay.
MAFLD is what they've called it now. Just about, I think, a few months back, they changed it. If you think of the insulin resistance and the visceral adiposity as the core, you'll understand that all of these are just the manifestations of that. The fatty liver, the PCOS, the dysglycemia, triglycerides, everything. And later on in life, as far as I'm concerned, the cancers, the heart attacks, the strokes, even dementia, depression, arthritis, everything ultimately at its core is related to that insulin resistance and inflammation.
Okay. Thank you, ma'am. Thank you. But it's very, very interesting to know that, PCOS, we are always so used to thinking about endometrial cancer, endometrial hyperplasia, but we all know that it has got a good prognosis, identified early and treated early. But it's very interesting to know that it has also a relationship between ovarian cancers and other cancers. But so, madam, once to Lakshmi, ma'am, one question, ma'am. Because we know that, this is hyperestrogenic state. So many studies quoted that there was a not much higher risk of breast cancer compared to endometrial. Why is it so, madam?
I don't think people have really understood the actual process involved. There is if the women are treated with combined oral contraceptive pills as part of treatment of polycystic ovarian syndrome, there is an increase in the breast cancer risk, but that is related to the COCs. But in general, everyone expected an increase in the risk. I think all the studies looked at it thinking they're going to get a positive association, and they have found a negative association. They have found that there are these genetic alterations which again are overlapping, but they are not, there is no explanation given as to why it is reduced. So most of them say further studies are needed. So I really cannot explain why.
Considering the obesity factor and metabolic factor, better to screen them.
Yeah.
Thank you so much, madam. Yeah. Thanks, everyone. It was a very, very enlightening session. We really enjoyed, and a lot of eye-opening things we learned from this session. And thanks to Shiny, because we all say, no, unave marandaga saapra naadu idu appadina. So your last tagline was that, no, food is considered as a medicine, because when we start eating food as medicine, I think we will not require most medicines that are prescribed, actually. Thank you so much. Thank you, everyone, for this wonderful webinar. And I request now, Dr. Any questions from the audience? Any questions? I think
Can metformin prevent cancers?
Metformin does not. Actually, it doesn't promote cancers. Unlike oral contraceptive, where everybody is worried about a breast cancer, metformin actually does not increase the risk of any of the cancers. Not the cancers that I'm talking about.
Okay.
What
Any questions
about the hyperplasia conversion to endometrial cancers in?
Yes.
You've seen this hyperplasias in women, conversion to endometrial cancers in young girls.
Mm-hmm. Yes, it happens. Whether it is associated with this PCOS or not, I think hyperplasia left untreated will in most cases progress to, especially the ones with atypia. If the hyperplasia is not associated with atypia, the risk is not very high. The risk is less than 2%. And therefore, but both generally need to be treated, but you can confidently treat the hyperplasia without atypia with hormones and not worry about it. You don't have to keep repeating the endometrial sampling. But those with atypia in younger women, even if you treat with levonorgestrel intrauterine device or with high dose oral progesterone, you have to repeat biopsies to make sure that it hasn't progressed. And you certainly have to do a DNC plus minus a hysteroscopy before you treat them with hormones to exclude an associated endometrial carcinoma, which is found in almost as high as 40% of them when you just only do a sampling. But yes, atypical endometrial hyperplasia is a forerunner of an endometrial cancer.
Ma'am, they say there's a
one question I want to have. Ma'am,
Hi,
one question I
Jairani.
want to have.
Hi, welcome,
Hi,
ma'am.
hi, hi. I just want to ask you one question, ma'am. Who are all the people who are high risk other than, is there any factor, like we say for BRCA, they have a high risk for breast cancer? Is any indicator, especially when we treat a simple hyperplasia, who are all the people who can go for an atypical? Is there any criteria to find out that these are vulnerable to go for a atypical? Is there anything like that? Because very many times we come across simple hyperplasia. When they ask this question, how we can go about it? Of course, we can treat them, we can correct them, but is there any factor which we can find out that these people are highly susceptible to go for this hyperplasia? Is there anything, ma'am, in your experience or in your studies?
In women with hyperplasia, other risk factors like obesity, diabetes, metabolic syndrome, all these are the ones that would increase the risk. In general, when you women are divided into those who are low risk for endometrial cancer, those at intermediate, and those at high risk. The high risks are the ones with HNPCC, that is hereditary non-polyposis coli or whatever. Those are the only group of women in whom regular screening for endometrial cancer is actually recommended currently. But the low risk women, of course, we just tell them lifestyle modification. The intermediate risks are the ones we focus on, and these intermediate risk women must be told that any abnormal bleeding you need to come and we will evaluate. And if they have a hyperplasia, if they have associated obesity is the one that really increases the risk because of the peripheral estrogen production by the adipocytes. And then of course if they have other risk factors as well, those are the ones which you will take very seriously. Look for atypia, and if there is associated atypia, if they are in the older age group, much better to do a hysterectomy with salpingectomy. If on the other hand they are younger and they have these risk factors, I think close follow-up is actually required with therapy for a minimum of 9 to 12 months. Actually 12-month therapy with progesterones or an intrauterine system is what is indicated. This obesity, the association with obesity and endometrial cancer, we see so often now. I have seen women who I have seen when they come as young girls and then they get married and come to me for delivery, they put on 10 kilos and then second delivery 10 kilos. After that another 10 kilos, and I tell them, please do something about your weight. At 50, they come to me with their endometrial cancer, and I have had at least 5 women in whom, and I think in individual practice, I think 5 of this is quite a large number. So I have taken to, I try telling them, and I don't think I have the positive experience that Shiny has, because none of my patients are off weight like that. They don't become, slim and trim after my advice. They either remain the same or put on more weight. And maybe I should send them to you, Dr. Shiny, in future. Anyway, so what I have started doing it, by the time they are about 45 and there is no reduction in weight, I introduce a levonorgestrel intrauterine system. And let it be there for the next 10 years, take it off when they are 55. At least I protected the endometrium. I can't protect the diabetes or other problems, but at least the endometrium, because then I don't have to operate on them, if you know what I mean, because this obesity and the cancer surgeries, even, so unsatisfactory, you don't get all the lymph nodes out, it's all a problem. Yes, this association is there and it is there to stay, I think.
Ma'am,
Kundami, you're going to ask me something. Yeah.
You were saying something about the genes, right? So who are the candidates who you would recommend that to test the genes?
I don't think genetic testing has really come in as a clinical testing for evaluation of these women. When they looked at why this association, why these cancers are happening in these women, they analyzed the genes, grouped them into polycystic ovarian syndrome associated, those with genetic alterations, and polycystic ovarian syndrome and those without, and they grouped them into two, and they actually analyzed to see whether the cancer driver genes are also involved in these or not, and they found there is some overlap. That is all there now. I don't think any more information is available, and I think once it becomes obvious as to which are these drivers, they've identified the driver genes, but even then they are not able to say which of these driver genes have to be definitely tested for. It's not come in the routine testing category at all. It's not like the BRCA. No, it's not come.
Ma'am, recently we had one of the medical onco who said that they do start testing these sort of genes, and depending on the presence or the absence of the genes, they even tend to go with the chemotherapy. So,
meaning this is after they have developed a malignancy. Now, endometrial cancer is all, the management has entirely changed. It's all based on the genetic, pole hypermutated and, those kind of things. That is once they have developed a cancer. It's not for those who have a polycystic ovarian syndrome. No. The context is actually different.
Yeah. And we know that PCOS is also associated with endometriosis. There's some
yes. The same genetic overlap is found there also. Yes.
So a patient who has got a recurrent endometrioma with the elevated CA125, and is there a risk of these women developing mucinous cancers, ovarian cancers? Because we have seen mucinous cystadenoma has been reported when we think it's an endometriosis.
There is an association between endometriosis and ovarian cancer, both with mucinous and endometrioid people have actually reported. But and there are the genomic alterations in endometriosis and in ovarian cancer and PCOS also overlap to some extent. There are studies on that. I didn't bring it in because the talk is only on the cancer. But again, all these are experimental. People are looking at it. Probably in the next 10 years, you will have some kind of an answer, I think, if not probably earlier also, but all these are being looked at the moment. No definite mutation to say that this particular woman will develop, because there is the list is just too long. There are 99 genomic alterations that are overlapping between all these three. And for them to figure out which is the most important mutation that is actually driving these is going to take time, and that has not been identified.
Thank you so much. If there are if you've answered all the questions, and now I request our Dr. Kalivani Madam give the vote of thanks. Dr. Kalivani Madam, I was her student when I was in Institute of Obstetrics and Gynecology. Madam is the director of, as present, the director of Institute of Obstetrics and Gynecology, and she has special interest in lot of things. Madam is a great academician. She has conducted a lot of workshops and basic obstetric skills, and UG and PG teacher, a lot of special awards, and best actor award by the Tamil Nadu Medical University, MGR Medical University. And Madam, over to you, ma'am, for vote of thanks. Madam, please unmute, ma'am. Please unmute, ma'am. Yes, ma'am.
Yeah. Feeling like not interrupting because we are getting valuable information, but anyhow, all good things have to come to an end. And it is indeed a great honor and pleasure to propose the vote of thanks for this wonderful seminar on PCOS. I like to thank the organizers for organizing this wonderful CME. Usually, as you said, we usually have clinical condition, pathophysiology management, but this webinar was completely different. Maybe we dealt from the start to till what it might happen in the future. So I like to thank the chairpersons, Dr. Shanti Gunasinghe Madam and Dr. Fatima, for chairing the session, compiling them and giving their valuable inputs. Our first speaker, Dr. Shaini, really gave a different aspect on eating disorders in PCOS. Thank you, ma'am, for your patience, how to select people who have eating disorders, how to counsel them, and all your clinical scenarios where you demonstrated that eating right or medicine is what we eat, gave a real transformation to all the women there, and may this will continue for all the patients whom we treat. And next, I like to thank Dr. Supraja on her talk on sleep apnea and PCOS. And I feel from now on, we should inquire about this condition in all the patients and treating them. And there was evidence where even the chairperson said that it made a lot of difference for giving CPAP for these patients with sleep apnea. So this history taking is very important maybe in future. And then I like to thank Dr. Jayashree Gopal on metabolic risk factors in thin and obese PCOS, where insulin resistance is the most important key factor in treating all these patients and how to go about it. Next, I like to thank Dr. Siddhartha on the various protocols in stimulating a resistant PCOS. He gave us a list of nearly 8 to 10 protocols which we should follow up so that we can have a good outcome. And finally, I'd like to thank Dr. Lakshmi Sheshatri ma'am about the long-term risks these women have, and we should be aware of all these risks. Maybe in future, when we have patients with we get patients nowadays in their 38, 39 with endometrial cancer. So maybe a previous history of PCOS, obesity, or anything in their history should be inquired, and the risk that they may encounter in future should also be explained to these patients. And Madam greatly explained about the genomic alterations that happens in these kind of women with obesity and PCOS. And finally, I'd like to thank all the delegates and participants for logging in on this Sunday afternoon and making this webinar a great success. Thank you, everyone and each one of you. Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you so much. A Sunday well spent.
Thank you, Karpagam, for helping us, and thanks Chitrakala and the team for giving us the platform.
Sahiti and Chitrakala and team
Thank
for
you.
the platform. Thank you so much.
Thank you.
Happy Sunday. Happy
Thanks.
Sunday evening to all of you.
To you all too. Okay.
Thank you,
so
Lakshmi
much.
ma'am. Seeing